Sonika, you can start, I think.
Okay, sir. Good morning, everyone. I'm Dr. Sonika Achali from the Department of Oral Medicine and Radiology, A.B. Shetty Memorial Institute of Dental Sciences, Nitte deemed to be university. It gives me immense pleasure to welcome all of you to the National Conference on the Current Concepts in Oral Cancer. Globally, oral cancer is the sixth most common type of cancer, and India is the second country having the highest number of oral cancer cases. Lack of knowledge, variations in exposure to the environment, and behavioral risk factors indicate a wide variation in the global incidence and increases the mortality rate. Prevention, early diagnosis, and timely treatment are critical aspects to tackle oral cancer-related burden. It is with this goal that the Department of Oral Medicine and Radiology has organized this conference. In the next 2 days, we have guest lectures by eminent speakers with topics ranging from early diagnosis to various treatment modalities in oral cancer. I request Professor Dr. Vidya, Head, Department of Oral Medicine and Radiology, to deliver the welcome address.
Respected Principal and Dean, Professor Dr. U.S. Krishnanayak, Vice Principal, Professor Dr. Mitra N. Hegde, President of the Indian Academy of Oral Medicine and Radiology, Professor Dr. K. Vinay Kumar Reddy, Honorary General Secretary, Professor Dr. Prashant Shenoy, eminent resource persons for the conference, and all our registered delegates, a very good morning and warm greetings from the Department of Oral Medicine and Radiology, A.B. Shetty Memorial Institute of Dental Sciences, Nitte deemed to be university. Cancer is a generic term that represents a large group of debilitating diseases affecting any part of the body. Oral cancer is a significant global health concern that ranks 6th among all other cancers. Significantly, higher rates of occurrence of oral cancers are reported in Asian countries, including India, where it is ranked as the 3rd most common cause of type of cancer. The prevalence of oral cancer differs widely across the globe, and these variations can be attributed to the diversity in ethnicity, regional and cultural differences, socioeconomic status, etc. The level of education and awareness among the population also plays a vital role in influencing the occurrence rates. I am indeed proud to say that the Departments of Oral Medicine and Radiology all over the country have always been in the front line in the screening and diagnosis of oral potentially malignant disorders and oral cancer. In today's scenario, there is a need for active research in terms of diagnosis and therapeutic modalities for a dynamic and effective management of oral cancer. The growth of technological inventions and adoption of various novel management strategies have led to improved survival of individuals with oral cancer. Hence, it is necessary for each and every one of us to be updated about the recent advances in cancer. World Cancer Day is an international day marked on the 4th of February to raise awareness of oral cancer and to encourage its prevention, detection, and treatment. World Cancer Day is led by the Union for International Cancer Control to support the goals of the World Cancer Declaration of 2008. The primary goal of World Cancer Day is to significantly reduce the illness and death that is caused by cancer. It is with this intention that we decided to organize a conference with the theme of oral cancer, including eminent speakers from various specialties. We are grateful to the Indian Academy of Oral Medicine and Radiology for their active support in our endeavor. We welcome Professor Dr. K. Vinay Kumar Reddy, Professor and Head, Mamta Dental College, Khammam, Telangana State, and President of the IOMR to this conference. We are thankful for the opportunity to associate with IOMR for this event. We have with us here today Professor Dr. Prashant Shenoy, Head, Department of Oral Medicine and Radiology, Yenapoya Dental College, Mangalore, and the Honorary General Secretary of the Indian Academy of Oral Medicine and Radiology. It gives me immense pleasure to welcome you, sir. I would like to welcome our dynamic Principal and Dean, Professor Dr. U.S. Krishnanayak, who has been extremely supportive in all our endeavors. I welcome our Vice Principal, Professor Dr. Mitra N. Hegde, to this conference, Her encouragement and her advice has always inspired us. I welcome Professor Dr. Pratima Srinivasan, Head, Department of Oral Medicine and Radiology, Kannur Dental College, Kerala, who has graciously consented to share her knowledge with us today. I welcome Professor Dr. U. Raguraj, Head, Department of Radiodiagnosis, KS Hegde Medical Academy, who has taken time from his busy schedule to be a part of this conference. Professor Dr. Kainikal CT, Department of Radiation Oncology at the Regional Cancer Center, Trivandrum, has kindly consented to enlighten us with his clinical experience in the field of radiotherapy. I welcome you, sir. I welcome Dr. Vilite, Associate Professor, Department of Oncology, KS Hegde Medical Academy, for accepting our invitation despite his busy schedule. Palliative care in oral cancer is a concept that is gaining momentum in recent years. I welcome Dr. Prajna Kini, consultant in palliative care, Yen Onco Center, who will be sharing her expert opinion in this field. Last but not the least, I welcome each and every delegate to this national conference on the current concepts in oral cancer, and I hope it will be a wonderful learning experience for each and every one of us. Thank you.
Thank you, ma'am. I now call upon our beloved Principal and Dean, Professor Dr. U.S. Krishnan Nayak, to formally inaugurate the national conference and deliver the opening remarks.
Very good morning to each one of you who have logged in for this conference. The President of the Indian Academy of Oral Medicine and Radiology, Professor Dr. Vinay Reddy, my very dear friend, our own proud alumnus, Professor Dr. Prashant Shanai, the Secretary of the Association, Head of Department, Professor Dr. Vidya Ajila, the other guest speakers. I see Pratima is also an alumnus of our institution, and we have got our colleagues, two of them from the KS Hegde Medical Academy, Professor Raguraj and also Dr. Vijit Shetty, who are here, Dr. Prajna Kini from consultant in palliative care at Yen Onco Center, and of course, Dr. Cecil from the Regional Cancer Center at Thiruvananthapuram. My other colleagues, participants, other guest speakers, and students and staff who are going to present free papers during the conference, and all the invited guests and participants. At the outset, I must say with conviction that I am really, should I say, privileged to be participating in this inaugural function of this conference on current concept in oral cancer being organized by the Department of Oral Medicine and Radiology of our institution, Abhishekti Memorial Institute of Dental Sciences, in association with the Indian Academy of Oral Medicine and Radiology. Well, since our Vice Chancellor had to be away, today he could not participate in this program, as is indisposed. So I have got this additional responsibility of inaugurating the conference as well. I was only supposed to preside over the conference, but all the same, it's not much of a difference, and it's only an added privilege, I would say. I would like to first of all congratulate Dr. Vidya, Dr. Sonika, and all the other members, the team behind this team, who have put together all the efforts to make sure that this conference sees the light of the day. And today, I'm sure they say, well begun is half done. So with this lovely beginning of the inaugural function, I'm sure the rest of the conference is going to go extremely well, and each of the participants are going to be enriched with knowledge at the end of 2 days of the conference. I should thank the Indian Academy of Oral Medicine and Radiology, the President, Dr. Vinay, and our own Dr. Prashant Shenai for, should I say, allotting this conference or associating with our Department of Oral Medicine and Radiology in hosting this National Conference on Oral Cancer. So, fourth, as Professor Vidya just said, is the World Cancer Day, commemorated the World Cancer Day. And she also went here to add that oral cancer is among about the 6th most frequent cancer in human beings. So we as dental professionals or specialists have a very important role in, I would say, rather preventing and also not to forget the curing part once it is there due to the various habits and our socioeconomic status and the tobacco chewing, reverse smoking, etc., etc. So I'm sure the oral cancer percentage in India could probably be much higher than 6%. I mean, it's not the 6th, I'm sure. It's about the 2nd or 3rd most common cancer in our country. So I will not take much more of your time. I'm sure you have got experts in the field who are going to share their know-how and specialty knowledge with all the participants. And I once again congratulate Dr. Vidya and Dr. Sonika for putting together this conference. For the next 2 days, all our delegates are going to have a feast of knowledge. And I would be failing in my duty if I do not thank the guest speakers or the guest faculty, should I say, Professor Dr. Pratima, Professor Dr. Raguraj, Dr. Cecil, Dr. Vijay Chetty, and Dr. Prajna Kini, who have graciously consented to be the resource persons for this conference. And all the other participants who are participating as in presenting papers, I'm not too sure there are poster presentations, digital, or I'm not too sure because it only talks of paper presentations in the afternoon session. But anyway, all the participants in every possible sense, I wish you all the very best and I wish the conference all success. Thank you very much.
Thank you, sir. Unfortunately, our Honorable Vice Chancellor, Professor Dr. Satish Kumar Bhandari, is unable to join us as he is indisposed. We have with us today Honorary General Secretary of Indian Academy of Oral Medicine and Radiology, Professor Dr. Prashant Shenai. Professor Dr. Prashant Shenai is currently Head Department of Oral Medicine and Radiology, Yenepoya Dental College, Yenepoya University, Mangalore. He finished his BDS in 1991 and MDS in 1995 from A.B. Shetty Memorial Institute of Dental Sciences, Mangalore. He is also a certified implantologist and is trained in CBCT technology from Helsinki, Finland. He has more than 200 publications to his credit and has delivered more than 50 guest lectures. He has held various positions in several professional organizations like President, Mangalore Junior Chamber, Secretary, IDA Dakshina Kannada Branch, Vice President, Indian Academy of Oral Medicine and Radiology, and is the current Honorary General Secretary of Indian Academy of Oral Medicine and Radiology. I request you, sir, to speak a few words.
Thank you, Sonika, for those nice words. Respected Dean, Dr. Yusuf Krishnaik, our own beloved Dean of A.B. Shetty, Dr. Mitra, Dr. Vidya, all the senior faculty of A.B. Shetty Dental College, and all the participants of today's event. Very good morning to you all. Today is actually a very special day for me. See, I have been attending a lot of programs in A.B. Shetty Memorial Institute of Dental Sciences, which is my own alma mater, maybe as a alumni or as maybe as a staff of other college under so many headings. And today is actually a special day for me. So I'm attending this function as a secretary of Indian Academy of Oral Medicine and Radiology. Okay. So I would have loved it to be offline and to come and say visit our alma mater. And okay, anyhow, so the distance is not much. Otherwise, the institute is close to my heart. Now coming to this national conference, which is on a virtual mode, that is a current concept in oral medicine radiology. Now, from Indian Academy of Oral Medicine and Radiology, we have made a policy to promote awareness among oral cancer nationwide. So actually, we are formulating a national IOMR national registry. So we are in verge of talking with Government of India. We are in terms of talking with the DCI, etc., to form a oral pre-cancer registry. Actually, we don't have a national level registry. So we are in a process of talking with the government, as I said, the DCI as well as with the government, because it may be a little bit long process. We have already initiated and we have done a very soft launch of this particular project. Hopefully, I am during my this tenure as another 2 years, I would like to take this forward. Now, as a policy, again, IOMR is associated with the various colleges and universities across India. Okay, we associate with them particularly, and we like, for example, program like this, we would like to associate more programs like this. Only IOMR can help to give news, I mean, spread the particularly what you call that information regarding these conferences pan across India, and inform all our members also to update their knowledge. So I really thank, as this particular, my tenure I took 1 month back, this process started along in my alma mater. So this is the first program where IOMR is getting associated with this national level program. Another probably every 3 months, we have planned this across India. So various universities and colleges will be conducting this program. Okay. So again, with this information, I would like to wish all the best for the team of Dr. Vidya, okay, who is conducting this program, and I wish them all the success. Thank you.
Thank you, sir. I now request Professor Dr. G. Subhash Babu to deliver the vote of thanks.
Good morning to the respected dignitaries. I indeed deem it my pleasure to deliver the vote of thanks of this national conference on the current concepts of oral cancer. So at the outset, I would like to express my sincere thanks to Professor Dr. Vinay Kumar Reddy Garu, the President of IOMR, for all the support extended for the conduct of this national conference. I also wish to express our sincere thanks to Professor Dr. Prashant Shenoy, the guest of honor and our proud alumnus, and currently the Honorary General Secretary of IOMR, for the strong support extended for the conduct of this national conference at his alma mater, that is A.B. Shetty. So thank you very much, Dr. Prashant, and we look forward to more eventful interaction and conduct of these programs. Also, I wish to thank our dynamic principal and dean, Professor Dr. U.S. Krishnayak, who has been the backbone and who has been very supportive in all our academic activities. Thank you very much, sir, for being there always. I also thank our respected Vice Principal, Professor Dr. Mitra N. Hegde, who has been very supportive in our initiatives and for a smooth launch or conduct of this national conference. Thank you very much, ma'am. I also thank the professors and heads and the teaching faculty of various colleges and universities, the postgraduates of various departments in and around Karnataka and other neighboring states, and also for registering very large numbers for this conference, which is of national importance. On behalf of the organizing committee, I also wish to convey our sincere thanks and are very grateful to the eminent speakers and some of them who are our alumni, for consenting to deliver the lectures over the next 2 days. Thank you all. I also take this opportunity to thank the judges for the next 2 days who have been very supportive and for sparing the valuable time for the poster and paper presentations. A special thanks goes to the staff development cell of the Nitte University, the IT cell of Nitte University under Mr. Mahesh Chauta, and the IT department of ABS MIDS for providing the logistic support by helping us with all these arrangements. Lastly, I also congratulate and thank Dr. Vidya for giving me an opportunity to give the vote of thanks, and also wish her and a team, including Dr. Sonika, who is a coordinator, and all the other teaching staff, and the postgraduates and the interns in the Department of Oral Medicine and Radiology for the great teamwork and for the hard work which has gone into making this event or this conference a success. Thank you one and all, and hope and wishing a happy learning over the next 2 days.
Thank you, sir. With this, we'll now commence with the first guest lecture of the day by Professor Dr. Pratima Srinivasan on the topic Early Diagnosis of Oral Cancer. I request Professor Dr. Vidya, Head, Department of Oral Medicine and Radiology, to introduce the speaker.
It gives me immense pleasure to introduce our first speaker of the day, Professor Dr. Pratima Srinivasan. Dr. Pratima Srinivasan is currently Professor and Head, Department of Oral Medicine and Radiology, Kannur Dental College, Anjarakandi, Kannur, Kerala. She completed a BDS in 2000 from the Tamil Nadu Dr. MGR Medical University and her MDS in Oral Medicine and Radiology in 2005 from our institute itself, that is A.B. Shetty Memorial Institute of Dental Sciences. She is the coordinator of the Memorandum of Understanding between Kannur Dental College, Anjarakandi Integrated Campus, and the University of Gothenburg, Sweden, with whom they have conducted many research studies. The topic of the current study is the role of human papillomavirus in oral potentially malignant disorders and oral cancer. She is also the supervisor of master's thesis done by exchange students from the University of Gothenburg, Sweden. She has many national and international publications to her credit and has also authored a chapter in the textbook of trigeminal neuralgia, Nova Science Publishers 2020. Yoga is one of her prime interests. She has undergone certification in yoga teacher training from State Resource Center, Kerala, and strongly believes that yoga training should be included for all dental students in India, similar to what has been done in schools across the country. Now, with these very few words of introduction, I extend a warm welcome again to Dr. Pratima. Over to you, Doctor.
Thank you, Vidya. So, good morning, everyone. Like when Vidya called me, when Dr. Vidya called me to invite me to speak in this forum, I was thrilled and worried, and in fact, I was so proud that I've been invited to my own institution. So A.B. Shetty is like my home. It's like my second home, and it will be forever close to my heart. And all the memories there have been wonderful memories, and it stays so. So I'm really proud to be part of this as a part of my own institution, the program conducted by my own institution. So let me start today. Can everyone see the screen?
No, ma'am.
No, not yet. Okay. Can you see the screen?
Yes, ma'am.
Yeah. Okay.
Yes.
So once again. So the topic given to me today is early diagnosis of oral cancer. So when I was given this topic over the years, of all the cases that I've seen, 3 cases or 3 patients flashed through my head. One was a patient which I saw in my 3rd year BDS as a part of my surgery postings, general surgery postings. So that was a patient of late stage or stage 4 malignant melanoma with satellite lesions all over his legs, probably 70-year-old patient. He was lying on the floor in the surgery ward in Madras Medical College. That was my undergraduate college. So that was the kind of help, or it didn't flash me then. Nothing seemed odd then, because that was the scene in the whole of the hospital of Madras Medical College, where patients could not, even in late stage disease, could not get beds. They used to be lying on the floor. It was a very common scene. But now when I think of it, I can understand the kind of health burden that the tertiary centers or the tertiary healthcare centers face. The second case is one more patient of erosive lichen planus I had in the institution I'm working, that is in Kannur Dental College. Probably we followed him up for 10 years. It was a recalcitrant erosive oral lichen planus, and probably we would have done 4 or 5 biopsies for him. And after a particular point, he didn't even want any more biopsies. And when he came back for, I don't know, maybe the 20th or 30th visit, so then it had transformed into a carcinoma. So there were so many times I had wished I could see what was going on inside the lesion without doing a biopsy. And the third person, the third patient was a very young patient, probably 30-year-old patient, who came with a small white patch in the lateral border of the tongue, with probably a positive history of smoking. And it was such a small patch in the lateral border of the tongue, and I was very sure it was probably just frictional keratosis. But because the patient insisted, we went ahead and did a biopsy, and it turned out to be carcinoma in situ. So luckily, he was diagnosed early, and without much of morbidity, the patient was treated. So these were the 3 cases which flashed through me, which emphasize the point that early diagnosis is a very, very, very important part of oral cancer management, especially in our country. So coming to the statistics, it's already been told, 90% of all oral cancer is oral squamous cell carcinoma. So it is almost synonymously used with the term oral cancer. And it is the 2nd most common cancer in India. And it contributes, or the Indian statistics contribute to total of 1/3 of total world cancer incidence. And recently, or probably in 2018, a study was published by Dr. Swati Sharma and colleagues, which was a compiling of information across 29 cancer registries of India, which states that the percentage is only increasing. There is no decrease in the recent or in the foreseeable future. So that is the state which we are in. So all of us know that oral cancer is not something which occurs suddenly. It goes through, the oral mucosa goes through several changes after being exposed to the risk factors, and then slowly it transforms into a carcinoma. In between, we also have the stage where it can be a pre-malignant lesion. Okay, there are different conditions also which can lead directly to a carcinoma, but mostly 90% of the lesions go through the pre-malignant stage, which allows us for enough time to assess the patient, to inform the patient, and to treat them at a very early stage. But in spite of all this, we see that we know that there are very well-known risk factors. There is ease of access to oral cavity, and it is preceded by potentially malignant lesions. It can be easily identified by visual examination, and community healthcare workers also can be easily taught about these lesions. But still, we see that there is a paucity, and there are so many patients who are detected in the end stage, leading to a severe healthcare burden. So what is the need for early diagnosis, as emphasized by Dr. Vidya and Dr. Sonika in the welcome address? So we see that there is an improved disease outcome and survival if the diagnosis is done early. There is also decreased morbidity and mortality if the condition is diagnosed early. And most importantly, there is a decreased burden on the healthcare system. So the amount of money that is spent in treating patients with oral cancer, or the amount of facilities that should be provided, is a big burden on the healthcare system, which can be avoided if only the lesions were diagnosed early and treated. So yeah, these are the photographs, or just photographs of all the pre-malignant lesions. These are photographs of leukoplakia, photographs of erythroplakia we've had in our institution. So all these are pre-malignant conditions which can be easily identified by visual examination and can be treated at this stage before it progresses on to the oral cancer stage. So let's come to how the workflow happens in the healthcare system. So normally we have the community healthcare systems, where in community settings, we have people, or we have healthcare workers going to people and screening them and identifying lesions. So this is a very important part of the healthcare system in India, because it helps identify diseases at a very early stage, or suspicious lesions at a very early stage. So in the health flow, these community care health workers then refer them to the primary healthcare settings. Usually it is the peripheral health centers or peripheral healthcare clinics, which are set up by several dental institutions in India, where probably there is a trained dental surgeon or a trained medical expert who can identify the lesion better. But most probably, there will not be any other diagnostic equipment or protocol which can help them diagnose further. So whatever suspicious patients with suspicious lesions are there should be referred further to tertiary care settings. So in tertiary care settings, hopefully they reach the correct person and they reach the correct place where they can be treated adequately. So all this, there is a large gap between the patient being referred from the community settings to the primary care settings and to the tertiary care settings. So like the proverb which says, there is many a slip between the cup and the lip. So there can be a lot of, lot of deviations for the patient, which can lead to the patient not reporting to the centers at the correct time and leading to a severe late diagnosis. So there are also a very important thing that we should know, which can be classified as low resource settings, which is unfortunately a realistic part of our healthcare infrastructure in India. So low resource settings can be classified as low resource settings if there is a lack of infrastructure, if there is lack of materials, or if there is a lack of human resources. And unfortunately in India, all three can be there in a single center, where there is a lack of infrastructure, lack of materials, and lack of human resources. This contributes, or this forms a great part of the reason why the patients are not referred adequately or the patients are not referred at the correct time to the tertiary centers. So in the process of diagnosis, there are two classified intervals, or this is the time period. The intervals are classified as time period which is taken for the patient to report to a center, or after the patient reports to a center, the time taken for the patient to be correctly referred and reviewed by a expert worker. So probably a oral medicine specialist or a general surgeon who is trained in oral lesions. So what is patient interval? It is the time taken or it is the time taken by the patient to report or to understand there is some lesion and report to a center. That is called patient delay. So that is called the patient delay or patient interval. So patient interval, lot of influencing factors. There are a lot of influencing factors. So mostly the first one is the patient should be aware that there is something wrong with them. So there should treatment because of multiple reasons. So accessibility to healthcare facilities is one of the most important reason. So there are probably patients who are like 20 kilometers, 30 kilometers away from the nearest peripheral healthcare center, and they would hesitate to come and report or spend money, whatever money they have, and come and report to the center, because they think they probably have something wrong. So they would comfort themselves by telling that there is nothing wrong with them and they would not even report. So there will be some patients who want to report but cannot avail travel facilities. And the last reason that I've cited here, that is the accompanying person, is one of the common reasons in a recent study that it is one of the common reasons why a patient does not report to the healthcare center. So these are the factors which can influence the patient interval and can lead to delay in the patient presenting to the center. So this is a recent research article which was published by Dr. Finze and colleagues. So this was his PhD study, and I have met him personally here. He works in the Malabar Cancer Center. So this was his article which examined the reasons for patient interval. So in the conclusion, they found that there are many patients who didn't want to discontinue their habits, that is the risk factors. And so they didn't even want to report to the center. And there were also some patients who wanted alternative treatments rather than allopathic treatments. So they preferred not to report. These were the two other findings which they had in their study other than what I have previously told. So these are the factors we should look at when we think of the patient from the patient point of view, which can delay the diagnosis. Now coming to the diagnostic interval. So what can influence the diagnostic interval? Or diagnostic interval is termed as the time taken from when the patient presents to a center to the time of final diagnosis and starting of the treatment. So the influencing factors can be the knowledge of the healthcare worker. So if it is a community healthcare setting, so probably the worker can identify there is a lesion, or some workers may not be trained adequately to identify. So it may, that itself will lead to a large amount of delay. Then the efficiency of referral systems, with how can the patient be referred, whether they can make sure that the patient is really going to the primary healthcare centers. Do they provide any facilities to the patient to go to the primary healthcare center or to the tertiary healthcare centers? And as and when the patient reports to the center, the availability of resources for diagnosis. So if you go to, or as I worked in peripheral healthcare centers during my undergraduation, I can understand this very significantly because it is an absolute lack of resources, and that is the reality which is there in the peripheral healthcare centers. So that itself can lead to a large amount of delay. And how the lesion progresses also is an important part of the diagnostic delay, because there are times when we see a lesion, like I told you, like the first or the third patient which I told you, which was a very small lesion, but it was a carcinoma in situ. So that also can influence the interval of diagnosis. So if it is, many studies have found that if it is an advanced lesion, it is diagnosed more easily when compared to a lesion which is not advanced. So it is, it makes the clinician very complacent when he sees a non-advanced or initial stage lesion. And when it is an advanced lesion, it becomes alarming. So the diagnostic delay is reduced there. So these are the factors which can influence the diagnostic interval. So the current paradigm or the workflow is after a patient reports to the requisite center or to the tertiary care center where the treatment can be given, after a clinical evaluation, the risk assessment is done, and there is presently a need for invasive tissue biopsy and histopathology, which is considered the gold standard. So right now there is no other procedure which can be considered the gold standard. So invasive tissue biopsy is the only option that is available for confirming the disease and for planning the treatment. So what is the need of the day? The disadvantages because of this is it cannot be performed. Biopsy can be performed only by skilled personnel, and so it cannot be performed at primary care settings. So that is a big disadvantage. It is an invasive procedure which cannot be performed multiple times. And if it is a large lesion, the site selection becomes a big problem. Even day before yesterday, we had a patient in our institution where the leukoplakia was present, or it was involving the entire buccal mucosa, which we still haven't decided which area to do the biopsy. And there is a time lag, at least about 1 week in obtaining the final report, because the process is like that. So these are the disadvantages of doing a histopathology for final diagnosis, but it is the gold standard and it has to be followed. So what is the need of the day? We have, or we should be looking at, or the recent studies are focused on non-invasive adjuncts. So non-invasive adjuncts are of two types. One is a screening adjunct, which can be used to screen a normal oral mucosa for suspicious lesions. And there can be a diagnostic adjunct which after identifying an abnormal lesion can be used to assess the abnormal area. So these are two types of non-invasive adjuncts where the present work is based on. So the ideal attributes that we should be looking at in a non-invasive adjunct is that it should be easily available, it should be user-friendly, it should be usable by anyone, and it should be inexpensive, and should be available or can be obtained even in low resource settings. So that will be the ideal attribute of a non-invasive adjunct. Probably it should be so cheap that even it can be provided to multiple community healthcare workers. So that will be the ideal attribute of a non-invasive adjunct. And it should be easily, that's, as I said, it should be user-friendly and should give consistent reports, even if it is not used by experts. And it should be non-invasive with high patient acceptance. And the result should be real-time, that is point of care. As and when we are seeing, assessing the patient, we should be able to obtain a report. So this would be the ideal attributes of a non-invasive adjunct. So as I was going through the literature, unfortunately, there is no adjunct which has all the properties in it at this point of time. But the comforting fact is that a lot of studies are going on and a lot of work is going on non-invasive edgings. Probably in the next decade, there will be leaps or leaps in research, and it will come into real practice. So the first screening tool, which is already existing, which I want to be talking about, is chemiluminescence. So chemiluminescence is a procedure where, or it is based on the rationale that this light that we use in chemiluminescence can be absorbed more by dysplastic tissue because there is more DNA material there, or there is active multiplication happening there, and it is absorbed more by these cells than by normal mucosal cells. So it is done, this kit comes with a chemical, acetic acid, whereby we do acetic acid wash of the oral mucosa, and we use this light, or the oral mucosa is exposed to this light, whereby the dysplastic areas or the malignant areas will fluoresce and the normal mucosa will not fluoresce. And this can be used to differentiate the suspicious lesions from the normal mucosa. So the disadvantage is that this light will also be absorbed by inflammatory cells, and so there can be a lot of false positive results. But in every article I read, the opinion was that it is better to have false positive reports rather than false negative reports. So this is a very commonly used screening tool right now. So Vilite is one of the commercially marketed chemiluminescence tools. It comes with it is a good screening device. It comes with a acetic acid, 30 ml of acetic acid, which is used to do the acetic acid wash, and then it is exposed to light. Okay. The disadvantage is that it is single use and it should be disposed after use. So that is the main disadvantage. So a lot of resources or economic resources are needed to buy this. It cannot be used again and again. So there is a limit to which it can be sourced. It can be sourced by the primary healthcare settings. Otherwise, it would be a very good screening tool. So the next screening tool is autofluorescence imaging. So this is, again, it uses the properties that the normal mucosa has inherent fluorophores like nicotine, adenamide, and there are so many other cytoplasmic material and organelles which can fluoresce or which can produce fluorescence when exposed to a particular wavelength of light. So this does not happen in abnormal epithelial tissue because of the changes in the organelles and the structures of the cells. So this light can be used as a good screening tool, whereby, so the picture will be like this, whereby the abnormal areas don't fluoresce and the normal areas fluoresce. So Wellscope is a very known marketed device of autofluorescence, which is currently in use. It is a single time investment that is needed. It is an equipment that can be bought by any primary healthcare center and can be used in any primary healthcare center. But the problem is that it cannot be used at a community level. It cannot be taken to a community level because the equipment has to be placed in a certain area, and we should have a dark room or a dark area to visualize the oral cavity, because only then the fluorescence can be seen properly. So these are the disadvantages. Otherwise, it is a very good screening tool. And even the amount of false positive and false negative results are less when compared to chemiluminescence. So this is upcoming technology, which is which has been researched in India, or it is the teams in India who have come up with this portal called mHealth. So it is there are a lot of studies being done on this, and it is an upcoming technology. So it is a very easy to use, where we should just have smartphones. And this mHealth portal is a portal which is developed where there are specialists who are integrated into the system, into the app. So what happens is, at the community screening levels, the community healthcare worker can go and take photographs, upload it into the mHealth portal, where specialists can have a look at it and say if it is suspicious or not, and do the subsequent referrals. So this cuts down a lot of time, or even the patient delay and the diagnostic delay. So this can help cut down a lot of the time and lead to early diagnosis. So this is the study or the mHealth prototype, which is being developed by Dr. Butt and colleagues. It was published in 2018. Further studies were also published by Dr. Monique Kurioko's team in Cochin Cancer Center. They've also been working on this. So they found that it really cuts down the time is in patient delay and in the diagnostic delay. So this technology, I think almost every one of us will have smartphones, and even the community healthcare workers can be easily trained to take photographs of the lesions and use adequate light. Now all the smartphones come with torches, so light is also not a big problem. It's just that they should be trained to take proper photographs, which can be interpreted properly by the specialists. So this is an upcoming portal. Hopefully it will be developed well enough, and it can cover even late stage diseases. This is right now being used only to screen for early diseases. So the next one, we are going on to from screening to diagnostic adjuncts. So this is a time-tested method, that is vital staining, which is being used time and again, and it has helped in narrowing down the site, or in narrowing in this site for biopsy, and helped us in correcting or obtaining the correct information so that we can choose the site for biopsy properly and obtain the correct information. So many vital stains are there. Of all of them, toluidine blue is the one which is most commonly used, followed by Lugol's iodine. So the procedure is again similar to chemiluminescence, where we initially give an acetic acid wash over the lesion and then stain it with toluidine blue dye. And the suspicious areas are stained, which can then be chosen as a site for biopsy. So since we can narrow down the site for biopsy, that will help us a lot in coming to a confirmatory diagnosis. So the only problem with vital staining is that it can again be absorbed by inflammatory lesions also, and so it can lead to false positive results. So as I said before, false positive is always better than false negative. So this is a technique which is still being used, and it is a very useful technique. Now, oral cytology is another technique which has been tested time and again and has withstood the test of time. So here, the rationale is that there will be shedding of epithelial cells from certain lesions. So these cells can be harvested and can be examined microscopically for any dysplastic changes. So this is the rationale behind oral cytology. But the problem is that if it is hyperkeratotic lesions like homogeneous leukoplakia or reticular lichen planus, or even initial stages of OSMF, exfoliative cytology cannot be used on these lesions because the shedding of cells will be minimal and cannot provide enough information for a diagnosis. So CDX brush biopsy is advanced exfoliative cytology method where a brush was developed which can penetrate deeper when compared to the spatula or a broom that we use when we are doing a normal exfoliative cytology. Beyond that, the procedure is the same. And it can also be, they also developed the program where it can be, the images or the microscopic images can be analyzed, computerized and analyzed. So still the time delay is, again, it is not real-time results like in chemiluminescence or toluidine blue staining. There is a time delay between obtaining the sample and getting the results, but it is much less than an invasive biopsy. So this also is a good diagnostic adjunct. So this is a picture of
Sorry for the inconvenience. I think there is some technical issue.
hello.
Yes, ma'am.
Yeah, can you hear me? Yeah,
Yes,
sorry,
ma'am.
there was a problem with the network.
It's okay.
Just a moment, I'll share the screen. Um, Can you see the screen?
Yes, ma'am.
Yeah, I'm very sorry. Yeah.
Okay, ma'am.
Wait. So there are emerging technologies which are coming up and are being researched. But still, it is a long time to reach, it would take a long time to reach the low resource settings where it is actually needed. But still, it is probably a light of, or ray of hope that we can have. So these technologies are based on the optical properties of the oral mucosa, which can be used to analyze the oral mucosa. So these are the technologies which are upcoming. So multimodal imaging or high resolution microendoscopy, optical coherence tomography, confocal microscopy, and multiphoton microscopy. These are the upcoming technologies. And there are many more based on Raman spectroscopy. There are many more narrowband imaging which are being investigated, but very few studies related to that. These technologies have much more research on them when compared to the other technologies. So a high resolution microendoscopy is a small equipment which can be used in any place. It comes with a fiber optic probe which can be used. This fiber optic probe, like an endoscopic probe, it is a small endoscopic probe which can be used on the tissue, and it gives real-time results. It is connected to a laptop where there is a program, and the results can be analyzed immediately. So that is a big advantage of this technology. So these are the images. So it is based again on the fluorescence properties of the oral mucosa. So it is theorized that, or the rationale is that the light will be absorbed more by heavily multiplying cells, and they will fluoresce more when compared to the normal mucosal cells, which are in the normal mode of division. So this is a picture of the normal mucosa. This is a picture of the abnormal area. That is, it can be, again, the disadvantages, even inflammatory lesions can also project such a image. So wherever there is increased cell growth. So this, and since the results are real time, it can be easily interpreted. But another disadvantage is that if you see, the end of the probe is very, very small. So the amount of area that can be imaged is very, very small, and so it is very time consuming. So a better mode will be to localize a suspicious area and then use such a microendoscope to investigate only that area to confirm the diagnosis. So that is high resolution microendoscopy. Now, optical coherence tomography is or very commonly being used in ophthalmology. Like all of us would have got our eyes tested regularly, and the machine they use there to analyze the sclera and the retina is optical coherence tomograph. It works on the principle that the different layers have different refractive indexes, and so the light projected back would have different values, which can be captured by a sensor and can give an image. So this is also called the oral ultrasound. The image is something like that. So, and the studies have found that the lesions almost, or the images obtained from suspicious lesions almost correctly correspond with the histopathology obtained from these areas. So optical coherence tomography also has good depth. It can penetrate up to 2 millimeter. So even the the basement membrane, and if there is a rupture in basement membrane, can be indicated by your optical coherence tomograph. So this is the advantage, and this is the most upcoming technology right now. And it can also be, so right now, because it is also being used in ophthalmology, it is cost effective, It is a single time investment. It can be used in many patients because the time taken to analyze the lesion is very less, not like a high resolution microendoscope. So a large area can also be visualized. So that is the advantage of optical coherence tomograph. And this is a very promising technology which is coming up. A confocal microscope is based on the principle, is another optical imaging technique. It is based on the principle that laser or focused light, when it penetrates the mucosa, it is reflected back at different levels by different kinds of tissue structures. So, and if there is abnormality, it is reflected back differently, which the images obtained can be used to analyze the differences. So that is the advantage of confocal microscopy. Again, it is something similar to our old fluorescence microscope. The only difference is here, it is the light is from a single point source, pinpoint source, so that only that area is imaged. Afterwards, the images are reconstructed, 3D reconstructed, and can be visualized on the computer screen in real time. So this is the advantage of using a confocal microscope. Again, this is an upcoming technology. Now, multimodal imaging is when we use another screening or diagnostic adjunct along with or two or more diagnostic adjuncts are used together to come to a diagnosis. So in this study, they used autofluorescence to image the lesion first, and they identified the suspicious areas, and then they used a high resolution microendoscope to analyze the lesion. So we here, the need to analyze the whole of the lesion was avoided because they used autofluorescence to analyze the lesion first, which can be used easily, and then they narrow down the area and examine the lesion. So this is how dysplastic cells will appear in a high resolution microendoscope. So these are the upcoming technologies, optical technologies, which can help in early diagnosis. But right now they are not very well developed. Hopefully in the next decade, they will be developed very well. So to summarize, multimodal imaging, optical coherence tomography, and confocal microscopy, multiphoton microscopy are technologies which have high sensitivity, but not much of specificity. When the only thing which has specificity is multimodal imaging, but the areas that can be imaged is very less when compared to optical coherence tomograph. So these are the advantages and disadvantages of these techniques. But one big advantage of all these techniques is that they are non-invasive techniques. And hopefully there will be a lot of research taking place in all these areas. Now coming to biomarkers, they have been a big question mark in oral squamous cell carcinoma, or for that matter, any oral cancer. And their usefulness is still a big question mark. So biomarkers can be predictive biomarkers and prognostic markers. So predictive markers are those which can indicate the risk of a malignant transformation and can assist in therapeutic intervention. So these are the ones which can be used in early diagnosis. But unfortunately, there are more than 100 markers which have been investigated in potentially malignant lesions and in carcinoma, but none of them have been found to be very specific to oral squamous cell carcinoma. So of them, these are the cells these are the markers which have been found to be more specific when compared to the other markers. So P53, P16 are markers which have been found to be very useful, and even Ki67. So the rest all have been found to be non-specific, and not much of a change is seen between the normal cells and these markers. So actually, this is the field of biomarkers has not been very helpful in diagnosing oral cancer or even predicting the path of a lesion or even helping in therapeutic intervention. So we have to talk about the role of HPV in carcinogenesis. So there have been a lot of studies which have done in oral squamous cell carcinoma and in oropharyngeal carcinoma. So HPV has found to be a very big positive factor in oropharyngeal carcinoma, but not so much in oral squamous cell carcinoma. So HPV, when it infects the oral mucosa, it can proceed like this. It can integrate into the genome into the host genome, and it produces two proteins, E6 and E7, which can deactivate the tumor suppressor genes P53 and retinoblastoma factor, which can then disrupt the cell cycle, because epithelial growth factor is one of the important factors which binds with retinoblastoma gene, and it can lead to disruption of the cell cycle. So this is how HPV acts. So markers for HPV have worked around this pathway. Of course, HPV infection can be assessed using technologies like polymerase chain reaction. It can also, polymerase chain reaction can quantify the amount of HPV that is present in the oral mucosal cells and predict the risk for malignant transformation, like in cervical cancers. But the studies in India and abroad have found that there is not much of a infection with HPV in oral mucosal cells. It is very high in oropharyngeal cells, but not so in oral mucosal cells. And there can also be geographical variations. Even in India, there can be geographical variations depending, it can also vary based on the environment. So the studies conducted on molecular markers in high-risk HPV, that is HPV 16 and 18. So the one marker which is promising is P16. So like in this graph, we see that there is a high expression, or there is a big decrease in expression of P16, which is a tumor suppressor gene in HPV positive patients when compared to HPV negative patients with squamous cell carcinoma or with potentially malignant lesions. So this is P16 is a promising marker which can be used after the patient is diagnosed as positive or negative for HPV. So the first step would be to analyze if there is a HPV infection, and the next step to assess the risk would be to analyze the P16 marker. So right now, it would require immunohistochemistry, PCR and immunohistochemistry, which are very advanced techniques, but probably in a tertiary healthcare settings to assess risk for patients after being diagnosed with, after a biopsy is performed to assess risk for patients, these procedures can be done. So probably these facilities will be available at the tertiary care centers at least, but definitely not at the community level and not at the peripheral healthcare levels. So to summarize, it is just like this: patient delay, to put it in the equation form, a decrease in the patient delay and a decrease in the diagnostic delay will lead to early diagnosis. This is a very, very simplified equation that I've put here. It is simply a decrease in the patient delay and a decrease in the diagnostic delay will lead to early diagnosis. But the steps that has to be taken to reduce both is formidable and a lot of work is there to reach the dream of, or to reach the goal of, early diagnosis. So to reduce patient delay, we should be looking at community awareness on risk factors. So mandatory community screening programs. It is unfortunately, because of the COVID pandemic, I can see that there is a lot of reduction in the community screening programs. Otherwise, I think I used to send out my postgraduates and interns to almost every month along with Malabar Cancer Center for screening programs. But for the past 2 years, it has absolutely come to a standstill. So there is absolutely zero screening programs that I've been seeing of late. Hopefully they will be revived again all over the country. And like there is a lot of education on breast cancer self-screening, that should also happen for oral cancer self-screening. The patient should be taught to self-screen. So though mouth is a very accessible area, visually accessible area, there is hardly any patient or any person in the lower economic strata who will be examining their mouth. So they probably, they will think it is odd to even look into the mirror and look into the mouth. So that kind of stigma should be avoided, and the individual should be taught self-screening. And improved healthcare referral systems. So that is a big question mark. That is still a big question mark in India. After we refer a patient to a primary center or a healthcare center or a tertiary healthcare center, we hardly know how the patient reaches those centers, or we don't even follow up the patients and see if they have reached those centers. We don't have any feedback systems right now in India to check if these patients have been diagnosed and the treatment has been given. And economic support is again a very important factor. So 2 years back, I was listening to 2 or 3 years back, I was listening to Dr. Moni Kuriakose talk specifically on this topic, and he was citing an example of a patient, of a lady, probably 40, 45 years old, who came to them with stage 4 oral squamous cell carcinoma. And the only reason, she said she knew she had a disease, and the only reason she didn't come there was because she didn't have the money to travel to the tertiary healthcare center. So that will be the scenario in most of the households in India, especially in the lower economic strata. And even in the economic strata where it is affordable, a lot of other psychological factors also influence the patient, like what will be the economic impact if it is diagnosed. We had a patient in our own institution where he committed suicide after being diagnosed with probably stage 1 OSCC, thinking of the economic burden he posed for the family if he has to undergo the treatment. So that is the kind of reality which we are facing. So economic support can be a very, very important factor in reducing the patient delay. So right now, among the diagnostic aids, biopsy and histopathology stands as the gold standard investigation. In non-invasive adjuncts, right now they're of poor accuracy, but still they can be used. Certain screening adjuncts can be used to narrow down the area and can be used in community healthcare settings, but not for the final diagnosis. Predictive markers are absolutely non-specific. Like I said, probably only P16 in HPV positive patients is only marker which has given positive results. And but still the analysis can be done only in a select few patients after they are confirmed for HPV infection. So right now we stand only here, that is biopsy, and histopathology is still a mandatory procedure. Probably in a decade's time, this can be different. I am really hoping for that. So yeah, Atomic Habits has been my very favorite book in the last year. And this is one quote from Atomic Habits, which I wanted to put. So it says, you do not rise to the level of your goals. You fall down to the level of your systems. So we can have a goal, but if we don't have a system in place, we will never reach that goal. So right now, that is the scenario in India. Our systems are not well equipped, and we have a long way to go in improving our systems and reaching the goal of early diagnosis and reducing the healthcare burden. Often I've wondered when I've gone into the Malabar Cancer Center, the amount of crowd that I see in the head and neck oncology section here. I wonder why these patients report at this stage. It is such a sad state for the patients, and the doctors, the surgeons, the oncosurgeons are also overworked there because of the kind of health burden that is placed on these systems. So hopefully we are progressing towards a better future. We can have better systems in place to reach this goal of early diagnosis. So I thank one and all for listening to this, this talk of mine. And at this point, I would like to thank a few people. That is my HOD during my post-graduation, Dr. Gopakumar. So I wrote it down in my thesis also in my acknowledgement. He let me be myself, which was very important to me. He gave me independence in thinking, which was also very important to me. So it was wonderful to be a PG under Dr. Gopakumar. And I also thank Dr. Babu sir, Subhash Babu sir, for the wonderful time and the discussions we've had with sir during my post-graduation. And my co-PG, Dr. Mansa, I always talk about her during any of my presentation because she was the first one to teach me how to make a PowerPoint. She patiently sat with me and taught me how to make a PowerPoint. So I'll never forget my days with Mansa as my co-PG, and all my other co-PGs, Dr. Vidya, Dr. Reema, Dr. Deepak, Dr. Naveen, Dr. Giridhar, and Sanjay. I had a wonderful time with them during my post-graduation. And finally, I would also like to thank Dr. Bengt Hesius and Dr. Joran Jeller from University of Gothenburg, who have been like mentors to me over the past few years. So any case, any discussions on oral cancer and discussions on HPV, I mail them and they mail back immediately. Even when I told them that I have a talk like this, they immediately sent me so much material to study and work on, and they gave me so much information which helped me in preparing this presentation. Yeah, and thanks once again. I hope all of you gained a little knowledge from the presentation. Thank you.
Thank you, ma'am, for the very informative session. Now we'll open the session for questions. There are a few questions asked, ma'am.
Yes.
The first question asked is role of nutrition and genes in carcinogenesis.
Yeah, like nutrition is a very important factor because what to say, a basic health is very important because after all, it is basic health which gives us immunity, and a lot of factors can be disrupted. A lot of protective factors can be disrupted if the basic health is not there. So nutrition is very, very important part of the basic protection. But once the disease starts, it is mainly nutritional supplements which can help the patient, like antioxidants and certain vitamins and pigments like lycopene, which can help the patient. So probably nutritional supplements can play a big role after we have diagnosed a patient. We recently did a study in our department where in lichen planus, we found that there is a big reduction in the antioxidant levels in lichen planus patients. So when compared to normal patients. So that can also happen in every other potentially malignant disease and definitely in oral squamous cell carcinoma. So nutritional supplementation and use of antioxidants can go a long way in as adjunctive management in oral squamous cell carcinoma. Regarding genes, as I told you, there is nothing specific as such till now in oral squamous cell carcinoma. And the only gene, that is the tumor suppressor gene, was found to be less expressed in patients who were positive for HPV. So this is the only, solid evidence that we've got to look for a biomarker. So other genes are very non-specific and can happen in many conditions. It is not found to be specific for oral squamous cell carcinoma.
Yes, ma'am. Thank you. Second question is role of nanotechnology in diagnosis.
Role of nanotechnology. No, there is not much of a development in nanotechnology, but saliva, I did come across some articles where they have used saliva as a sample and used nanotechnology to analyze the biomarkers, but the study results were found to be very non-specific. It is still a very upcoming field, and a lot of work has to be done in nanotechnology to use it for early diagnosis. It is at a very rudimentary level.
Yes, ma'am. Okay. The next question, is it advisable to perform diagnostic biopsy within the general dental clinic or directly refer the patient to a tertiary care hospital specializing in oncology, considering the lesion which we may examine, but it may not be the only lesion within the body?
Okay, yeah. So, this is something, I've been a lot of patients with pre-malignant diseases have been referred back from the Malabar Cancer Center here, which is a tertiary cancer center here, and they have referred back to us because they absolutely don't have time. The healthcare burden is so much on them. They don't have time to look into this small lesions. So if you have a facility to do a biopsy for a diagnosed pre-malignant lesion, I would say yes, please go ahead and do it in your clinic. And if you can do the basic diagnosis and send them with a report to the tertiary center, it will be helpful. But if we see that it is an advanced oral squamous cell carcinoma, or if you feel that it is an advanced lesion, it is better to refer them there, because again, we are delaying them or we are creating a diagnostic delay.
Yes, ma'am. The last question. Can all forms of lichen planus transform into oral cancer, or is it only the erosive form that has the malignant potential?
Yeah, right now only erosive has been classified as, even according to the recent classification, only erosive has been classified as a potentially malignant disease. Reticular, very less, but even the bullous form is being considered as a potentially malignant condition, probably because of the exposure of the connective tissue to all the factors. But the reticular form and the atrophic form have not been classified as potentially malignant.
Okay, ma'am, thank you. Thank you for a very informative session. Kindly accept our certificate of screen share.
Okay.
We'll set the certificate of appreciation. Okay, ma'am. It's okay. We'll send it to you anyhow, the certificate. Okay, ma'am. Okay, ma'am. Thank you. Thank you, ma'am.
Thank you. Yeah.
We'll now move on to the second guest lecture of the day by Professor Dr. U. Raguraj on the topic Essentials of Cross-Sectional Imaging in Oral Cancer. I request Dr. Shruti Hegde, Leader, Department of Oral Medicine and Radiology, to introduce the speaker.
Good morning. It's my privilege and honor to introduce our eminent speaker, Professor Dr. U. Raguraj. Sir is presently working as Professor and Head of Department of Radiodiagnosis, K.S. Hegde Medical Academy, Nitte deemed to be University. Sir has a vast academic and clinical experience of over 13 years. Adding to his credit, Sir has authored numerous international publications and national publications as well. Sir has delivered guest lectures in various national and state conferences. Sir has been resource person in certificate courses on CBCT being conducted by our department since August 2017. Sir is also a distinguished speaker and has contributed to various workshops and conferences. Workshop on Pediatric Critical Care Procedure and Imaging, November 2012, Imaging in Clinical Forensic Medicine, OSCE workshop, comprehensive exam-oriented tutorials in anesthesiology, to name a few. He has a special clinical interest in the head and neck imaging. Sir is executive committee member of IRIA, Dakshin Kannada chapter, member of Shema Center for Genetic Services. Sir is specialist associated with PMJ Clinic. It is such an honor for us to have you today with us, sir, as a resource person. Over to you, sir.
Am I audible? Audible?
Yes, sir.
Yeah.
Yes, sir.
Okay. Good afternoon to all. At the outset, I thank my introduction and giving for us a nice introduction of my career, and I also thank for giving this opportunity to the HOD of the Department of Oral Medicine and Radiology of A.B. Shetty Memorial Dental Institute of Sciences of the Delakata, and also Dr. Subhash sir, another senior person who is in front of me. Advantage for me is I have a small audience here, and I'm happy to sit in the boardroom of the institution. Without much delay, I'm going to talk about the cross-sectional imaging in the oral cancer. So gone are the days where you used to assume the things on clinical examination. Now it is the evidence-based medicine. So we usually evaluate everything on imaging. So today I'm going to introduce you to the CT and MR imaging of oral cancer. The objectives of my presentation are that you should be able to choose optimal imaging modality by the end of my presentation. And you should be able to understand the radiological anatomy of specific pattern of spread of carcinoma of the various oral cancers, and should be able to detect the important imaging clues which are relevant to the clinician for further decision on the management. So we know that we have many imaging modalities. So if you see, the primary ones are the orthopentagram or the radiographs. So they are very basic modalities, not much useful unless there is a gross bone erosion is there. So they cannot pick up any soft tissue component of the lesion. Now coming to the ultrasound, so with a high frequency probe, we can evaluate a very superficial lesion. So we can see the depth of the lesion, whether it's going to underlying muscles or to the overlying skin. And we can also evaluate in such cases, we can screen the neck for any regional nodes. So other than that, so if a surgeon decides to go ahead with the local wide excision for a superficial lesion, he can always ask for an ultrasound as a screening tool to detect the neck nodes. Subsequently, if the lesion is actually advanced more than the superficial lesion, one of the cross-sectional modalities has to be advanced, either CT or which I am going to discuss in detail today. And the important thing is PET CT. The popularly spoken nowadays, it's a functional imaging modality plus combined with the anatomical imaging. The advantage of the PET CT is that when you want to evaluate the distant nodal metastasis or distant organ metastasis, for evaluation of the primary lesion, it is not a primary modality. So this PET CT is advocated only when there is a distant disease or when we want to evaluate the distant organ metastasis in an advanced cancer. Now, coming to the incidence, I think already my previous speaker spoke about this. So you all know that the oral carcinoma contributes for about 30% of the head and neck malignancies. And in India, the age-adjusted incidence is about 20 per 1 lakh. We all know that tobacco chewing and the alcohol are the risk factor or the causative factor. And also the 90% of the malignant lesions arising from the oral cavity are squamous cell carcinomas. The remaining 10% is contributed by the minor salivary gland rest tumors, which are malignant tumors arising from minor salivary gland rest in the oral mucosa, the lymphoma, and the mesenchymal tumors. So today I'm going to tell you the imaging findings on the squamous cell carcinoma. So we all know that the most common location is the gingival region, and oral tongue and retromolar tribunal followed region for the subsequent involvement. In India, the lower gingival complex is the most common location which is involved because of the pattern of tobacco chewing. And this is also called as Indian oral cancer because of keeping the tobacco under the lower vestibule or the close to the lower buccogingival sulcus. So with this introduction, now we'll move on to the basics of the CT. So we know that the multi-detector CT has revolutionized, and when you want to evaluate a malignancy, it is always the contrast CT. The plain CT is of not much useful. The plain CT is advocated only when you want to see some calcification in the lesion or when you want to pick up a bony erosion, which you already confirmed on some other modality like MRI or on a high frequency ultrasound. So in those cases, we can do a plain CT and check the bone erosion. But if it is, you have to evaluate the soft tissue, then it is always post contrast. So I'm just going to tell you what is this contrast. The contrast is nothing but an iodinated material which is injected intravenously just before doing the scan, and you subsequently take the CT scan of the part of the interest. So one important technical aspect in the evaluation of oral cancer is the puff cheek technique. You have to tell the patient to do the puff cheek while doing the scan so that you push the the buccal mucosa very laterally and separate it from the gingiva. That's the most important technical point to evaluate the buccal carcinoma. And we always should do a multiplanar reformation so that we can see the extent of the lesion every side from all the sides. And we have to obtain about 1 mm or less than 1 mm thin reformats to see the images better. We should do 3D reformations to see the relationship to the bone or to the adjacent vessels. We always take from base of skull to the diaphragm level because in addition, there are two aspects. One is we have to see the upper limit of the lesion because once it goes to skull base, it is beyond dissectable stage, a very advanced disease. Second, as such, we are doing CT. The most common location of metastasis is the lungs. So we can at least in the same sitting, we can also evaluate the lungs. So that is the point why we take the sections from the base of skull to the diaphragm. And important is that we should always see these images on both bone and the soft tissue window, because certain things are better seen on soft tissue window. When you want to evaluate the soft tissue lesion, it has to be soft tissue window. I'm just going to show you that in a short while. So you can see this difference between the plain CT and contrast CT. On left hand side, you have an image of the plain CT. On the right hand side, you have the image of the contrast. You see the contrast CT, the oral carcinoma tongue, very large ulcerative lesion on the base of the tongue, which is hardly made out on this plain CT. You can't actually make out. And you see the vessels which are all brightened up because of contrast. Now I know, I'm very sure when I'm telling a lesion is going close to the vessel or there are nodes, all that I can make out on a contrast, which is not made out on a plain CT. So you must ask for a contrast. That's the most important thing. So what we give about 100 to 200 ml of the iodinated contrast material at the rate of 2 to 3 ml per second with the power injector. and images should be acquired about 20 to 25 seconds. Why 20 to 25 seconds? Because the concentration of the contrast will be maximum during that 20 to 25 seconds period, so that the tumor which have the neovascularity will enhance best and be seen best on that particular image. As I told you, the puff check is the most important technique. You tell the patient to puff his cheeks, and then you can see that the buccal mucosa is very clearly separated from the gingiva there. See on this axial image, the buccal mucosa is very clearly separated, and you can see a mass there arising from the left buccal mucosa. Otherwise, you would have totally missed it. I'll just show you on contrast when there is patient is not doing a puff check. See these two axial images. The buccal mucosa is slightly opposed to the gingiva. You can't make out where the growth is coming from, whether there is a small growth, we'll totally miss it. On this coronal, you can also see when puff cheek is not done, you can't make out the difference between the buccal mucosa and gingiva again. See this particular one and see this. So that is how puff cheek is going to be very helpful in CT. Now, multiplanar deformants, you all know that once we obtain the axial sections, we can reconstruct it into the sagittal and the coronal planes or any oblique planes. The advantage is that you can see a large lesion here from the supraglottis, from the epiglottis. You can very clearly see on the sagittal that it is from the tip of the epiglottis. And coronal, you can actually see the lateral extent of the disease. So that is the advantage of multiplanar deformant. So we should evaluate on multiplanar deformation. Then the volume rendered images, where you can produce the bone, the calvarium, or you can superimpose the vascular structures on the calvarium to see basically whether the lesion is close to a bone, whether it's causing a bone erosion, or it is getting close to the vessel. All that we can evaluate on the multiplanar deformation and the volume rendered images. Now coming to the window setting, as I told you, we must see on a soft tissue on bone window. See the difference between these two images. The first image, it is a soft tissue image where you can clearly see that the buccal mucus thickening, a very ulcerative lesion, also proliferative lesion there, very clear. And we can see some erosion of the mandible. But see how best it is shown on this bone window, that a very wide erosion just close to the third molar, and we can actually calculate and see measure the length of the erosion. All that can be seen better on a bone window. That's why we should always put it on a soft tissue and bone window, check it on the reformat, so for the clear evaluation of the lesion. Now, yeah, these are your friends, I know, but I am afraid of these things. Dental process, I am very afraid of these things. I know it makes your life very easy, but for me it is very difficult. You see with this image, totally blurred and all beam hardening artifacts, I don't know where the lesion is sitting. So we will totally miss this kind of with the artifacts, but there is a technique wherein you can adjust the gantry angle so that to some extent you can kill the issue and show the buccal mucosa better. So you can see that if you angle it to some extent, we can overcome that. Now coming to the MRI, so I'm not going in detail about that T1, T2 and T3. I'm going to share, because I don't want to confuse you on these issues. But just remember that whenever there is a T2, that is double T. Think of having double T, not coffee, so it is more liquid. So all liquids or the fluids are seen bright on a T2 weighted images. And the second is T2, fat suppressed. Remember, wherever fat is there, that is suppressed, that will look black. So we should have a dedicated 1.5 or 3 Tesla MRI at least, and it should be lower than that. And we should use the neck coil. This is how the neck coil looks, very frightening, a cage-like thing. You know, many patients get afraid of claustrophobic, they don't want to undergo the MRI. But this is the one which gives you the best image. And we should obtain the images in all the planes. As in CT, we once obtain axial plane, we can generate the coronal and sagittal or oblique. But in MRI, it is usually not possible. You can take 3D and do it, but usually what we do is we take separate sagittal or coronal images in a different place. And puff check technique for the matter of MRI, we can't always advocate. Maybe 1 or 2 sequences we can ask the patient to keep the puff check. Otherwise, I think by the end of puff check will be just will not be able to hold on, because you know the duration of MRI is for about half an hour or 45 minutes for the entire sequence. Patient will not be able to keep the mouth puffed or till all that sequence through the sequence. Here also contrast is very important. The MRI contrast used is small quantity, that is 10 ml of gadolinium, compared to CT where used 100 ml. Oh, though this is 10 ml, this is also nephrotox. So important thing you have to know that in CT and MRI contrast, they are usually nephrotoxic. So patients who are having borderline renal function or renal failure cannot undergo the contrast CT. So what can we do? So best is that we can at least ask for a plain MRI. So that will sort out the issue to some extent, because plain MRI will at least have a very good tissue contrast compared to the plain CT. So we can ask for a plain CT we can't ask for a plain CT, which is of no use. So instead we can go for a plain MRI. These two MRI techniques would like to tell not usually done, but they are very useful. The diffusion weighted imaging, wherein you can pick up the malignant lesions of the malignant lymph nodes. And the diffusion weighted technique, as you know, that diffusion is nothing but the free movement of the Brownian particles, Brownian movement or the molecular movement. Basically, it is the movement of the water molecules between the cells. Wherever there is cancer or a carcinoma, there will be proliferative cell growth and there will be very closely packed. So there will be less of intracellular space. So movement of the water particles will be restricted. So once it is restricted, that area will look bright on a MRI. So that is the technique used for the diffusion weighted imaging. And spectroscopy is basically the functional imaging wherein it picks up the metabolites. You know that carcinoma has a rich in cells, and there will be more of the cell membrane proteins like the choline can be picked up on a spectroscopy to say that it is a malignant lesion and not a normal tissue. So these techniques will be useful whenever we are doing the evaluation of the recurrent disease. Coming to the basic sequences, as I told you, T1 and T2, you just see this fluid in the mouth. This is the saliva, looks bright on T2, dark on T1 there. So other than that, it's a coronal cuts. You can see the maxillary sinus looks dark on both T1 and T2. See the subcutaneous fat, intermuscular fat, they all look bright on both T1 and T2. So this is the technique I told, T2 fat suppressed, wherein you suppress the signal from the fat, then only the tumor and the important tissue will remain bright, so that we can figure out the lesion very clearly. So these are the coronal cuts. Now this is the contrast. See the difference between this T1, both are T1, but you see the sublingual gland, which is very bright there on either side. This is the soft tissues of tongue. These are the vessels and the mucous membrane. So they all are lightened up because of the contrast. So this T1 fat cell plus contrast. So we are given the contrast with the fat suppressed technique. We are obtaining T1 weighted image will look like this. These are the sagittal images. You can see how best see this is very important to see here. This is cervical canal. You can see the CSF fluid that is bright on T2. If you take a T1 sagittal, that will be very dark. So that is how we can make out the difference between T1 and T2. So this difference between this sagittal and this sagittal is that this is fat suppressed. You can see fat is totally dark here. So this is the tongue. Very clearly you can see the intrinsic muscles, the genioglossus and the geniohyoid. This is the saliva in the mouth. This is the hard palate, soft palate, the oropharynx, the lips you can make out, and the laryngopharynx. So we'll go into that subsequently. So this is basic axial sections. So this is the T2 weighted sequence. Here you can see the fluid is bright there. So the oral cavity, central oral cavity, the alveolus of the mandible. You can see the buccal mucosa. That dark band on either side of the buccal mucosa is the buccinator muscle. And you can see part of zygomatic major there. This is the buccal space, which is filled with the fat and bright looking. And this is on fat suppressed. Same thing. You can see parotid gland on either side. This is the masticator space with the ramus of mandible in the center, masseter muscle, medial pterygoid, and the buccal mucosa. Now this is on contrast. You can see the mucous membrane is enhancing there very clearly. So this is fat is suppressed on T1, fat suppressed post contrast, as I have shown you in the previous coronal. Similarly, so you can see the parotid gland, the mucosa, the alveolus of the maxilla, and this is the subcutaneous fat which is turned dark there. So this is the T1. You can see that CSF is dark here, CSF is bright here. So all of you are, I'm very sure, very familiar with the subsides of this oral cavity. I'm sure I'm not going to repeat that. And you know that is starting from the lips, most anterior parts. Then you have laterally have the buccal mucosa, the upper and lower alveolar ridge. Then we have the retromolar trigone, an important triangular area behind the mandibular third molar, oral tongue, the floor of mouth, and heart. So lips, the buccal mucosa, there forms anterior and lateral portion. Then the alveolar ridges on either side. The central portion is by the tongue and the floor of mouth. superiorly by the the hard palate, and retromolar trigon requires a special mention. I will just going to show those lesions subsequently. Why is it important that the cancer staging is depends on the from which subside the lesion is arising from? So these are the CT images, the axial and the sagittal. So we know that oral cavity starts from the just from the lips anteriorly to the posteriorly on axial, which you see that is circumvallate papilla. But you see the thing that circumvallate papilla is not made out on imaging, but that is the LOC between the oral cavity and the oropharynx. So this LOC is not very tight like India-Pakistan LOC. So you all know the lesion can go across all this both the sides. So on imaging, we have a difficulty in basically making out which is the circumvallate papilla, but based on other structure like tonsillar pillar, we can basically see the boundary. But on sagittal, we can draw an imaginary line from the posterior tip of the hard palate, that is junction of hard palate to the soft palate, then inferiorly into the hyoid. So whatever comes anterior is oral cavity, whatever is posterior to that is the oropharynx. So we can actually put a cursor and see it on axial, coronal. So whether we are seeing in oral cavity or in the oropharynx. So that is the imaginary line of the oropharynx. So well, see, I told lips, yes, this superior and inferior lip. You can see the vestibule. So not a good puff cheek, but still you can see the soft tissue left very clearly. So this is the tongue, soft tissue of tongue, hard palate, soft palate, the nasopharynx, the oropharynx and laryngopharynx. Then you can see the hyoid here. So this facial muscle is the genioglossus. Genio hand is coming straight here. When we see the MRI, those muscles will be seen very clearly. So this is the axial image at the level of the lips. So patient is done a puff cheek, but not so deep, but still we can see the separation of the buccal mucosa with the gingiva. So that's most important thing to do. Now buccal mucosa, so when patient does the puff cheek, you can see very laterally here on either side, the buccal mucosa is separated from the gingiva. So we can very clearly evaluate. On this coronal also, you can see the buccal mucosa is very clearly separated from gingiva. So this is superior and inferior buccogingival sulcus. So we should evaluate all these areas very clearly. So this is the central oral cavity with the tongue, floor of mouth, and the hard palate, the maxillary sinuses on above. Some more anatomical images of the buccal mucosa on MRI. So we can see the buccal mucosa on this axial T2 weighted image very clearly. So this is the alveolus at the teeth, and then this is the soft tissue of tongue. You can see small that black stripes, they are the intrinsic muscles of the tongue, and the central bright line is the lingual septum. So on this second image, which is fat suppressed T2, you can see CSF is bright and fat is suppressed. Otherwise, it is like a T2 weighted image. You can see the parotid gland, a very nice looking parotid duct is going all the way from parotid gland to the buccal mucosa there. So we can evaluate the parotid duct very clearly on MR. We can do the MR cyclograms and see whether parotid duct is actually involved. So this is the coronal image. As I shown you, this is the superior and inferior buccogingival sulcus, buccal mucosa. This is the buccinator muscle there, and this is the maxillary alveolus, the mandibular alveolus, the gingiva, the maxillary and mandibular, the tongue, the genioglossus, the sublingual gland, and mylohyoid muscles. So coming to the retromolar trigone, an important area. So you all know that when you slip your tongue behind the third molar of the mandible, so you will end up in the retromolar trigone. All those who have got their wisdom tooth removed, they have a good news. They have a larger site of retromolar trigone. So they have a big plot. Okay. And you know that it's basically an inverted triangle, and with the base towards the mandibular molar, and apex is towards the maxillary third. So in between is the portion of the mucosa of the retromolar trigone is resting on the anterior edge of the inferior ramus of the mandible, close to the. So on imaging, so this is the CT cut. You can see that this is the buccal mucosa. This is the ramus of mandible. This particular area is the retromolar trigone. This is the third molar. And if you go laterally, it leads to the buccal mucosa. If I go posteromedially, it leads to the tonsils. So this is the tonsillar region on either side. So this is the anterior tonsillar pillar, and this is the tonsillar region. And also posterolaterally, very important structure, that is the masticator space there. The ramus of the mandible, outside we have masseter, inside we have the medial pterygoid at this level, and this is the parotid gland. Now on this sagittal oblique image. This is very important to see on CT. We have to reformat and get this particular reformatted image to see the soft tissues of the retromolar trigone. So this is the entire retromolar trigone there. And also we should see evaluate the mandible there, very important. Because the early retromolar trigone cancer can even erode the mandible because it's very close to the bone there. And also it is also close to the maxilla superior. Also an important structure not to forget, that is pterygomandibular raphe. So pterygomandibular raphe on, we can't make out on imaging, but this is the one. Basically, it is the junction between the buccinator anteriorly and posteromedially, it is the superior constrictor. So that is the main important area. The pterygomandibular raphe, it is connected superiorly to the pterygoid hamulus of the medial pterygoid plate and inferiorly to the posterior end of the mylohyoid ridge of the mandible. So any growth in the retromolar trigone can, this structure can become a conduit and the tumor can spread along this pterygomandibular raphe into the base of skull. That is why there's an important structure lying under the retromolar trigone. Coming to the retromolar trigone anatomy and MRI, this is how it is made out. CT we have already seen. So this is the area behind the third molar, the retromolar trigone. And you can see here the ramus of the mandible. So this is the masseter, this is the medial pterygoid. And this is on the opposite side. This is the tonsillar fossa. So this is the anterior tonsillar pillar. So you know that it's very closely related to the alveolar ridge anteromedially or anteriorly. Also related to the buccal mucosa laterally. Posterolaterally related to the masticator space. Posteromedially related to the tonsillar fossa. So that is why it's actually like a highway junction. I think if you come to the background, it is something like an Antur cross or a pump well, where the growth can go to the anywhere. This can go to Kasaragod, it can go to the BC Road, it can go to Udupi, anywhere it can reach. So similarly, you can see here another sagittal reformatted image of the MRI. Very clearly, the fat surface technique, you can see the inferior alveolar nerve there, or inferior canal. So retromolar trigone region, if it erodes, it can very easily reach to this, the inferior alveolar canal. So that's why we should be seeing it also on a sagittal images to evaluate all these structures. So floor of mouth, yes, it is a central portion of the mouth, but it's inferior limit. And on the CT image, you can see the soft tissues of tongue. And this is the lateral edge, the gingiva, the lingual gingiva on either side. So just slightly inferior cut, you can see a strip of soft tissues here. These are the mylohyoid muscle, which you can see. This is the tongue. This is the lingual septum and genioglossus fibers we can see. On either side, this blob of enhancing tissues are submandibular salivary glands. So these are the submandibular lymph nodes. We can see small, some of them there. So this is the oropharynx posterior. Now these are the carotid vessels on either side. Now coming to the further down, we can see these two strands which are nothing but the anterior belly of digastric there. This is a part of hyoglossus which you are seeing there. And this is the tip of epiglottis of the oropharynx. You can still see some portion of the submandibular gland there. Now coming to the coronary image CT, where you can see very clearly that the mandible body on either side, this strip of muscles are the mylohyoid. This is the anterior belly of digastric. This is the soft tissue of tongue. This is basically genioglossus and geniohyoid. And then we have the neurovascular bundles of the tongue there within the sublingual space, also very clearly made out there. This is slightly more posterior cut, wherein you can see the submandibular salivary glands on either side. And at this level, we are seeing more of the masticator space, where there is a ramus of mandible. This is the medial pterygoid, this is the masseter, and this is the lateral pterygoid. So you can see relationship to the floor of mouth there. And this is on sagittal. You can see that this is the mandible, the midline, anterior. This is hyoid. This type of soft tissue is the geniohyoid. And this fanning out muscle is the genioglossus. We can't make out intrinsic muscles of tongue on a CT. So we'll see it MRI. So this is the hard palate. This is the oropharynx. Now coming to the MRI anatomy, the floor of mouth, you can see the submandibular salivary glands on this axial cuts. These are the anterior belly of digastric. This is the hyoglossus muscle. Now this is the intrinsic muscles of tongue. We can see more clearly here. And this black strip of the muscles are the hyoglossus. And if you go more laterally, this black strip of thin muscles are the mylohyoid. So mylohyoid is a U-like U-shaped sling, basically, which is there at the floor of the mouth. So most of the surgeons use the terminology floor of mouth as the mucosa covering the floor of mouth. But for radiology, we usually take from the mucosa till the submental space. And at this level, we can see that submandibular gland and its ducts very clearly. You can trace it to sublingual region. Submandibular salivary ducts on either side. This strip of soft tissues are the sublingual glands, and this is the mandible body there. Now, more axial cuts where you can see more superior cuts, soft tissue of tongue. I told you these are all the intrinsic muscles. This is the lingual septum, and we can see clearly on these coronal images that this is the myloid, and this is the sublingual gland. So this portion is also called as root of tongue by surgeons. Basically, this is a bulk of genioglossus and the geniohyoid, whereas this is the proper tongue prop, mobile part of the tongue. This is the fixed portion. This is called the root of tongue. These terminologies are important when we are explaining to a surgeon, that when they ask whether it's going to root of tongue, then these two black stripes which you are seeing are the anterior belly of digastric in the submental region there. So this is submandibular region. So this is the mylohyoid muscles. So this is more posterior cuts. We can see some strip of mylohyoid there. This is the hyoglossus, tongue. Then you can see submandibular gland on either side. This is the masticator space on either side. So this is a sagittal image, very clearly showing you the geniohyoid, genioglossus fibers fanning out. This is the longitudinal, the intrinsic muscles, superficial and deep. Lip, the mandible anteriorly, the oropharynx, epiglottis, base of tongue. This is the root of. So with this basic imaging, I'm just last part, that is the hard palate, important area. They are better evaluated on CT than on MRI because you know the very important foramina are the incisive foramina and the greater palatine foramina. Because whenever there is a growth in the hard palate which is very close to this foramina, they can always go as a perineural infiltration across this foramina to the skull base. So when they reach the skull base, again it's again in operative stage. This is a very vital information because this on clinical examination of the surgeons can't see this. Only on imaging we will be able to tell whether there is a perineural infiltration. So this vital information we should provide on a imaging. So this is a sagittal cut showing you the hard palate, the soft palate, and the tongue. On the coronal, you can see very clear the hard palate separating the oral cavity from the maxillary antrum on either side and the nasal cavity there. So the axial image is very important. These are the pterygoid plates, maxillary sinus, medial plate, lateral plate of pterygoid, and this is the greater palatine foramen. This is the incisive foramen. So all these areas we should. So incisive foramen is anterior midline, whereas greater palatine is either side posterior. So all these areas we should carefully evaluate. Now coming to the staging of the oral cancer. So I am going to tell you basically on a T staging. You can see this is a recent the T staging system where this is the 8th edition brought out by the AJCC, that is American Joint Commission on Cancer, brought out in 2017. Why I'm stressing upon the 8th edition is that there are some changes made up from the 7th or the previous edition. And you can see on this table that in addition to the tumor size, the side by side they are giving DOA. What is DOA? It is the depth of invasion. So we have to very carefully seeing the depth of invasion, which I'm going to show subsequently how you measure the depth of the invasion. Depth of invasion, you see, it is a T1, it is less than 5 mm. And if it is between 5 to 10 mm, puts it into the T2 staging. In spite of lesion being less than 2 centimeter, if depth of invasion is more than 5 mm, that puts it into the T2 stage. And T3, when the depth of invasion is more than 10 mm, of course, the lesion has to be 4 centimeter. But if lesion is not 4 centimeter, we have to take the criteria of depth of invasion, because this has a bearing on a metastasis and the surgical removal. T4 staging, there is not much difference compared to the 7th stage, except for the removal of extrinsic muscles from the T4A staging, which I'm going to show side by side on this good article. They have compared side by side the 7th and the 8th edition. So we can clearly see that depth of invasion is included in the present edition. And you just very carefully see this T4 staging, that is the extrinsic muscles of tongue, which has been taken out from the present staging, and they have what they have included is extensive tumor with bilateral tongue involvement. And depth of invasion should be more than 20 mm. So that is the criteria for T4A. So T4B, there is again no change. So other stages, as I told you, they have added the depth of invasion. So when it is T1, less than 5 mm, that is T2 between 5 to 10 mm. If it is more than 10 mm, puts away straight away in the T3 staging, and beyond that, T4A. So we'll see some examples of the malignancies now. And on this image, you can see a small lip cancer there. And this is the enhancing on CT. On MRI, you can see this the hyperintense lesions there. So what we have to see in a lip cancer is that whether the underlying bone is eroded or not. That's a very important thing. And what is the extension? So you can see in this growth, there is definite erosion of the mandible there, which you hardly appreciate, or you can't make out very clearly how much is exactly the erosion. So you can see the growth there on the lip and which is eroding on the bone. So important thing that you have to basically see the most common location. We all know it's Ormilian border, but perineural infiltration is most important information. So when it invades around the mental foramen, if there is a widening of the foramen, or if there is enhancement along the foramen on contrast CT or MRA, so that says that there is perineural infiltration. Again, I tell you, it cannot be made out clinical. So that is why this is very important information. And the level of lymph nodes are usually first and second level lymph nodes. Coming to the buccal carcinoma, and you can basically, if you see here, this patient with a 65-year-old male with ulcerative proliferative growth of the left cheek lesion, a very large extensive lesion there. There is an ulceration. Though skin is intact, you can see posteriorly the masseter is invaded. You see the contralateral masseter. It is normal thickness. This is thickened. This is enhancing, more brighter than this side. So that is how it is continuously infiltrates through the submucosa into the adjacent structures. As you go slightly higher up, you can see it is extending to the retromolar trigone as well. And you see the medial pterygoid on opposite side, and this is the medial pterygoid on the normal side. This is the medial pterygoid on the affected side. You can see that clearly the medial pterygoid is also thickened and enhancing. So this is an extensive lesion straight away going to the masticator space, and definitely this puts into the T4B. So this is invading to the space, and that is why it is a T4B lesion. Now the same on a coronal, you can see the ulcerative lesion. Very clearly you can see the extent of the lesion to inferior and superior buccogingival sulci. Superior and inferior. More posterior cuts, and you can see on this bone window a clear erosion of the mandible. This is a very important sagittal oblique deformation. We must see all cases of bone erosion of mandible on this sagittal deformation. Then only we will be able to tell or confidently tell how much is the erosion, what is the length of the erosion, whether it is going to the inferior canal, whether the leftover mandible thickness is enough for if they go for a marginal mandibulectomy, or they have to go for segmental mandibulectomy if it is more erosion is larger. So all that we can mention only on the sagittal oblique deformation. So that is very important to see that erosion. So coming to buccal carcinoma, usually they are mostly low-grade tumors. They spread submucosally, as we have seen in our case, go to the buccinator, masticator space, or nearby spaces. Most commonly, it spreads to the gingivobuccal surface, more commonly, and to the retromolar trigone. What is important is to note whether there is erosion of mandible or maxilla, and we have to see the extension into the maxillary sinus. All this puts it into the next stage of the disease. Then we should always see the extension, whether from the secondary from the retromolar trigone, it is going to the pterygomandibular raphe. So whether there is a widening of the posterior maxillary soft tissue is thickened, or there is erosion of the maxillary posterior wall, all this we have to see. Lymph node, as in a previous lip cancer, we are mostly at the level 1 and 2 lymph nodes we can see. This patient was a 42-year-old male, came with the painless swelling of the cheek. On examination, oral mucosa is looking intact, but still patient has a tobacco chewing habit, and we are all confused. And on ultrasound, when I did, it was looking like a hypoechoic lesion. So anyway, they went ahead with a guided biopsy, and what it has come as a non-Hodgkin's lymphoma. So remember, so all masks are not carcinomas. So clinical clue is very important. When they say mucosa is normal, you must always think of lymphoma, which can occur anywhere, everywhere. And also in buccal region, always remember the minor salivary reds, they can throw out malignant tumors anywhere in the oral cavity or the oropharynx. So we should be thinking of in other angles when the mucosa is intact. Now this lady, 65 years old, she had a non-healing ulcer on the left cheek. You can see a very extensive growth. You see the maxillary alveolus is totally eroded there. It is going to the masticator space, even eroding the maxillary anterior wall, and it is filling up the maxillary sinus there. and posteriorly it is merging with the masticator space there. And the important thing is that you can see the pterygoid plate and it's almost reaching there. So that is why we should see it on all the angles. Now, how good we can make out this bone erosion, you can see on this coronal deformated bone window. You can see that it's also eroding the hard palate there. It is entering into the maxillary sinus, eroding the floor of the maxillary sinus, almost reaching up to the orbital floor there. Also going the superior buccogingival sulcus. So this is again a very advanced T4 disease. So in the earlier classification, this was told as very advanced buccal carcinoma. So moderate and very advanced, that is corresponding to T4A and T4B. So now it is T4A and T4B based on the depth of invasion. And now coming to the another lesion of the inferior alveolar ridge RMT. This patient has a growth in the inferior alveolar ridge there, but it is also going to the retromolar trigone very clearly. You can see posterior to the third molar there of the mandible, and you can also see the tonsillar pillar which is thickened there, anterior tonsillar. See the contralateral side, it's normal. So this is thickened. So and you can see on coronal very clearly, it is also creeping on to the floor of mouth there, lateral border of tongue. You can see the enhancing soft tissue there. And this, you can see very how close it is to the mandible. You can make out very clear. So we have to see on bone window whether there is an erosion. So this is the very important image. As I told you, the sagittal oblique. You can see the mandibular margin. This is not very smooth. You can see it is slightly irregular, or you can see on coronal image, or you can see here a irregular margin. This candidate is ideal for a marginal mandibulectomy because there is no significant erosion of mandible. It is only the superficial erosion. The alveolar canal is not involved, and the good segment of mandible is still left over. Posterior segment is fine, condyle is fine, and you see on the soft tissue image of same oblique lateral or sagittal oblique image, you can see the thickened soft tissue going from the alveolar ridge to the retromolar trigone. Also, it is going posterior to the maxilla. So entire retromolar trigone is involved. Now, whenever you see so there requires a special mention in case of the retromolar trigone cancers. They are very difficult to assess clinically because patient usually will have the trismus because very early it invades into the medial pterygoid. CT is the primary modality. MRI can be useful. So you should see for all the extension of the lesion, including the perineural spread. So you can see that from the retromolar trigone, it can go anteriorly along the alveolar ridge, either mandibular or the maxillary. It can go medially into the floor of mouth or into the base of tongue or the tongue basically. And then posteromedially, it can go into the tonsillar pillar. Posterolaterally or the laterally, it can go to buccal mucosa, and posterolaterally, it can go to the masticator space. So all these extensions are very important to assess. That's why I told it's a major junction where the growth can go to anywhere. So we have to evaluate all these areas. So if you remember this image, then you will definitely remember to see all these areas. So superior, inferior extension, then posterior, and the anterior extension and the medial extensions. So you have to see superior the maxillary alveolar ridge, pterygopalatine fossa, maxillary alveolus. Posteriorly, you have to see the tonsil posteromedially, and the base of tongue medially and floor of tongue. So laterally, you have to see buccal mucosa, also posterolaterally masticator space. Inferiorly, you should always check the mandibular, alveolar ridge, and inferior alveolar. Now, so remember one important thing: the lesion arising from any surrounding structures can also secondarily get into the retromolar trigone and be confused for a primary retromolar lesion. So this is on retromolar trigone lesion on MRI, where you can see very clearly contralateral retromolar here, and this you can see a lesion here, just abutting the third molar of the mandible there. And how close is this to the ramus, you can see there, and it is also invading into the medial pterygoid. So this is another, you can again show it is also going to the tonsillar pillar and tonsillar region. And now on this coronal, we can very clearly say that, see the contralateral side and this side, the lesion is going into the sublingual and floor of mouth, also the lateral border of tongue. So oblique images are very important. We should see the relationship to the mandibular ramus. So this is further cuts of the same patient. On contrast, you can see very enhancing lesion. See the contralateral trigone, the retromolar trigone looking normal. And the important information, you see this buccal mucosa, very minute finding, but it is thicker. So it is definitely going to the buccal mucosa there. Posteriorly, it's also going to the tonsillar region there. So this is another cut showing the close proximity to the mandibular ramus there. You can see the mandibular ramus is eroded. The tumor is entering there. On the sagittal first cut, it looks like normal. You go more medially, and you can see that there is subtle erosion of the mandibular ramus there. And inferior alveolar canal is intact. So as I told you, mandibulectomy, two important things are it is either marginal or segmental depending on the type of the erosion. So if it's erosion is very subtle or minimal, patient can do very well with the marginal mandibulectomy. The function is preserved very well, a very good surgical outcome. If it is segmental, large portion of mandible has to be removed, which has to be replaced by the graft. And you can see there's such a large growth if it is going on to the inferior alveolar canal, or if the leftover mandible is less, then patient has to go for a segmental mandibulectomy. So when we are evaluating for a mandibulectomy, the imaging has an important role. So for subtle erosions, which can be detected only on CT, not on MRI, so marginal mandibulectomy is fine. Criteria is that at least 1 centimeter height of mandibular body should be available at the level of the erosion, and patient will definitely have a very good prognosis and functional things will be preserved. If the segmental mandibulectomy, there is a large erosion, then it has to go for a segmental mandibulectomy, which involves the alveolar canal or mental foramen, or if there is less than 1 centimeter of the mandible left over because of the erosion, and if there is a very large soft tissue on either side of the mandible, paramandibular soft tissue, or the edentulous mandible, which is not very thick, and if it is an irradiated, following radiotherapy, very thin mandible, a destroyed mandible, so all these conditions patient have to go for segmental mandible. And you know that these patients will not do good with post surgery, the poor outcome, and they will have to end up with a bone graft, so function may not be preserved. So what is the role of imaging? What is the role of radiologist? What he has to tell in his report? So we should always mention whether the buccal cortex, whether it is lingual cortex, whether it's occlusal cortex, whether there's involvement of inferior alveolar canal, all these things we have to mention. Remember, for assessment of marrow, it is always MRI. CT cannot show marrow changes. If there's a reactive marrow edema or a subtle marrow infiltration, this can be made out only on a MRI. Then we have to see the anterior posterior extension of the involved mandible, as I shown you, the uninvolved mandibular body height, preservation of the condyle or the posterior segment. All these are important to be mentioned. And then remember, we should always check on a sagittal oblique CT, comment all these things. CT has a very good specificity of 87%. SPECT and MRI imaging have a good sensitivity, but there is a lot of overestimation. So most of the people stick to the CT for evaluation of the mandibular issue. So this is a very good article which says that very good specificity with the CT. So compared to the MRI, there is almost good specificity. So it's always good to do an CT whenever we suspect the bone erosion. This patient who had a large buccal carcinoma was operated, and you can see the hemimandibulectomy, and this patient has come with a large local recurrence there. Now it is even infiltrating on the skin there and even going medially into the tongue as well. So this is how the large erosion looks. And coming to the carcinoma of tongue, this patient has an ulcerative lesion over the dorsal aspect of the tongue, and you can very clearly see a lesion. Normally, we saw the previous images how the genioglossus fibers were seen. Here you can't make out because it's all infiltrated by the lesion. This is how you can see the genioglossus fibers. They are emitted. This is the depth. I'll show you how the depth is calculated. This is the genioglossus, geniohyoid muscle, which is intact, but genioglossus fibers are all infiltrated. So this is soft palate, hard palate, the mandible. On this coronal, very good evaluation of the floor of tongue can be done. You can see very clearly the growth is going into the floor of mouth on that side. Irregular surface of the tongue, you can make out this entire thing is a lesion. You can how big is it, and it's also crossing midline. So this is another image showing the extension to the floor of mouth there. And here also you can see the extension to the floor of mouth, the entire lesion. And this you can see very carefully. There is a rounded structure peeping in there on the contralateral side. That is the node which is important. It's a rounded. The normal nodes will be usually reniform or a kidney shape, whereas bean shape, whereas the involved nodes will be, though they are small, they can look very round. So you can see that the lesion is on the contralateral side, but the contralateral node has come up. So it is important to evaluate these nodes and mention in our report. So I have been talking about a lot about the depth of invasion. So you can see here, I'm just showing you how the depth of invasion is calculated. or a measure. So the first thing is that we should draw a line along the lateral border of the tongue, vertical line. Then we draw a perpendicular line to that from the lateral border tongue till the growth is there. Extreme edge of the growth on the opposite side. So this tells us the depth of invasion. In this case, it is straight away 2.4 centimeters. So it's more than 20 mm straight away puts in the T4 stage. And why is it important? See, the pathologists have found out that when the tumor size is more than 4 mm, it increases the possibility of nodal involvement. Also on imaging, if you see the thickness of involvement is more than 10 mm, the surgeon should always go for elective neck dissection because there is a high chance of being a nodal metastasis. On this axial image, you can see a large growth occupying the right half of tongue there. It's also going to the lingual gingiva there, and also it is going to posterior tongue. So this is on contrast. You can see a nicely enhancing lesion. Some areas are non-enhancing. They're all the necrotic areas of the tumor. You can see it is also invading onto floor and the retromolar trigone there. So floor of mouth, it's invaded. Sublingual space is invaded. So when we come to the carcinoma of the oral tongue, you must always see that the most common location is lateral border and the ventral surface. So we should look for depth of invasion. It's a very vital information. Involvement of intrinsic and extrinsic muscles should be evaluated. And important thing, whether it is crossing the midline or encasing the contralateral neurovascular bundle. So when it's so, then it precludes a partial glossectomy. Patient has to go for a total glossectomy. The extrinsic muscles involvement is actually removed from the old staging system. Presently, it is basically the large tumor with the bilateral involvement. So this you have to remember. So laterally, it can go to lingual gingiva or the mandible, and most commonly involved are jugulo-digastric and jugulo-omoid nodes, which has to be evaluated. This is another patient, 65 years old, with a large oral the tongue carcinoma. We can see the almost entire tongue, even the base of tongue, the root of tongue, the genioglossus, the geniohyoid, genioglossus, everything is involved. A large growth, and you can see a neck node there at level 2. On this coronal image, you can see that it's going to the floor of mouth. It's invading the mylohyoid muscle, going to the submandibular space, invading the submandibular gland. You can see multiple nodes in the level 2 neck nodes there on either side. You can see in the nodes there are central hypodense or non-enhancing areas. That tells you that it's a necrotic node. And there are multiple matted nodes here in level 2. And this is an important information here. This is an and the involvement. See, you can't make out the limits of the nodes very clearly. And you can see that the IJV on this side very clearly made out. This IJV is chinked, narrowed, and it's encased by the node. So there is encasement of the vessels. So this is an infiltrative necrotic node. This is a CT image of a base of tongue lesion, large ulcerative lesion here, which I showed at the beginning. And this even going to the base of tongue there, even going to the valvular anterior border. And important thing, you can note here, there are the two nodes, the necrotic nodes on either side. So this is how CT is very useful, evaluating primary lesion and the also the nodes. So coming to the floor of mouth, one example I'm just showing here. So this was a primary floor of mouth on the right side, floor of mouth lesion, also under surface of the tongue, which is invading onto the mandible, the sublingual region there. You can see it's going to sublingual region. This is on contrast, enhancing lesion there. So this is enhancing lesion. And very important information that submandibular duct is getting entangled by that lesion there on the sublingual region. So this is the floor of mouth lesion. So important that you should see for whether it's extending to sublingual or submandibular region, floor of mouth. We should see the mylohyoid strip, whether it's going to the other side of mouth. So you can see the mylohyoid in this corner. So we should always see whether it's crossing it. And invasion of the muscles of tongue, whether it is, in this case, you can see it's going to lateral border, but not invading the extrinsic muscles. We should always see whether it's crossing the midline. Again, the glossectomy may have to be undertaken, which can be decided based on whether it's crossing the midline. So lateral involvement, gingiva can be involved laterally. And to the one more case where I'm just showing you the carcinoma of the heart palate there. So this patient's sagittal cut, you can see a lesion there, and very clearly seen on this coronal image, enhancing lesion there. What is important for us is this is a plain T1, and you can see on contrast it is enhancing. So this is very close to the greater palatine foramen there. So we should see whether the enhancement is there on the foramen. And on this axial, you can see the greater palatine foramen here. On the left side is very clearly widened, and there is some soft tissue there. You can make out on this arrow. And this is how the things are shown on MRI. You can very clearly see the enhancement going along the greater palatine now. On this oblique, you can again see the enhancing thicker now. So there is a clear perineurial infiltration. This is the information we have to give on imaging. So very important to show the perineurial infiltration. Now will be thickened, it will be enhancing, there will be widening of the foramen. So carcinoma of the hard palate. So important that we should evaluate coronal always to see the foramen. On CT, we may just see like the widened foramen or the dilated canal, the greater palatine canal we can see. And we should always evaluate the maxillary alveolar ridge. Posteriorly, we should see whether it's going to the soft palate. And important is to evaluate the foramen. Okay, I have 10 minutes. So perineal spread is an important. So on MRI, we have is the optimal imaging modality. You can see enhancement of the nerve, and we can see thickening of the nerve. We can see the loss of perineal fat, which is there otherwise normally. And CT, we can see the widening or the erosion of the foramen. So always MRI takes the compared to the CT for evaluation of perineal spread. So remember, whenever you see oral cancer, see the spread along submucosa, see the spread into surrounding structures, look at the perineal spread, look at the lymph nodal involvement. So first image here you can see buccal carcinoma extending along the submucosa into the masticator space. It is eroding the bones, adjacent structures. You can see on this coronal image that hard palate lesion is getting into the greater palatine foramen there. So it is thickened and enhancing. So nodal involvement, look for the necrotic nodes. You can see a bunch of matted necrotic nodes here, which is encasing IJB. So we should evaluate all those. It is more common with the retromolar trigone and the floor of mouth cancers. About 50% of the patients present with the nodal metastasis at the imaging we can see, and followed by the oral tongue. Least common with the lip, hard palate, or the buccal carcinoma. And important clue, we should always see for an extra capsular enhancement, as I told you, because this increases the chance of local recurrence by about 3.5 folds. So here are the nodal criteria. Though for the short axis, size more than 11 mm for jugular digastric and 10 mm for the rest of the neck nodes. Not always reliable, because even the nodes less than this can also have a occult malignancies. But not very useful, but rounded nodes always to be viewed with a suspicion. Necrotic nodes are most important. As you can see here, the necrotic node is a rounded node. Necrotic nodes are most important. They are the signs of malignancy, nodal spread, and extra capsular spread, an important clue which we should always see for, because it will encase the vessels. So that's an important information. Though we can use diffusion weighted MRI, PET CT for evaluation of neck, we can always rely upon CT and MRI for the regional nodal metastasis. And another important thing regarding the resectability of the tumor. You see that involvement of the skull base, or when a lesion is encasing more than 270 degrees circumference of ICA, it precludes the surgery, and also mandibular notch, an important reference. Because though lesion is T4B, when masticator space is involved, if the disease is infranotch, that has a good or a favorable surgical outcome. If the supranotch, that is the lesion is going above the notch of the mandible, though it is T4B, the surgical outcome is very poor. So this is how we can make out on a CT. If we put a reference on the notch, so this is how the supranotch looks. You will see more of lateral pterygoid, coronary process, and the condyle. So if the lesion is reaching here, it's a supranotch disease. So if for the infranotch, you will see the single ramus, the bone there, and you will see the medial pterygoid is the reference. So if the lesion is at this level, this is infranotch. If lesion is at the lateral pterygoid or condylar level, that is supranotch disease. Now, another important thing surgeons speak is infratemporal fossa. This is nothing but the medial masticator space, the space which is medial to the ramus of the mandible. So the muscles are the lateral, medial, pterygoid, temporalis. Some portion of the parapharyngeal space are all included in this. So when we say high infratemporal fossa, it corresponds to the supranotch disease. So what we see is lateral pterygoid and the upper third of the 2/3 of the pterygoid plates. So that is the level. When we say infra-notch, it is at the level of medial pterygoid and is basically lower third of pterygoid plate and below that. So we should always mention in our report whether it is going high or low or supra or infra-notch disease. So almost coming to the end of my presentation. So I think my objectives I have almost made it clear. So remember, when you want to choose the optimal imaging modality, it is CT. Always buccal mucosa and RMT lesions and bone erosions are made best on CT. Of course, lungs can be evaluated simultaneously in the CT. That's the added advantage. But when you do an MRI, your added advantage is you can simultaneously see the intracranial metastasis, the brain metastasis. And it is best for oral tongue, floor of mouth, and when you want to look for a perineural spread or you want to see the bone marrow changes. Remember, they're always complementary. So for soft tissue, MRI takes the lead because of its excellent soft tissue resolution, and CT has advantage in showing the bone erosions very clearly. So PET-CT is not a primary modality. It is of use when you want to evaluate the distant metastasis. Remember, occult nodal metastasis again cannot be picked up on PET-CT. Also for evaluation of initial lesion, PET-CT is not an ideal modality. Now, ultrasound, I told you, it is useful only for superficial lesions. You can use the high frequency probes, and screening of the cervical nodes can be done in the early carcinomas where you want to go ahead with the wide excision to rule out the neck nodes. So important take home message is that when you see the carcinoma of oral tongue, always look for depth of invasion, which matters the T staging in the present classification. Look for invasion of the neurovascular bundles, which can be made out very well on MRI, and extension across the midline, which precludes the hemiglossectomy and the type of management. When you want to evaluate oral cavity, that is peripheral oral cavity, puff cheek is very important technique in CT, where you can throw out, push the buccal mucosa laterally, and evaluate buccal mucosa and gingival carcinoma very clear. Also, bone erosion can be made, should be evaluated in all oral cavity malignancies. RMT lesions, as I told you, all extension pathways should be evaluated very clearly, and perineural invasion is a very important information which can be given only on imaging, which cannot be made out clinically or by the palpation. So with this, I would say that the imaging is a very important component of the management of oral cancer. It supports the clinical findings and helps the clinician to plan appropriately the treatment, and very informative, important information regarding the surgical resection, extent of resection, whether they require reconstruction, all that can be told on imaging. Also, it can prognosticate the treatment outcomes in extensive lesions. And in addition, it is helpful in evaluating the local lesions. I have completed. I have tried to keep it simple. I know maybe some things are few things are complicated. So I welcome any questions. This is a very good view which you can see from the Someshwar Beach. You all must visit our place.
Thank you, sir. It was a very informative session. Now we'll open the session for questions. There's one question, sir. Whether any most sensitive or specific cross-sectional imaging can be, any imaging view is there for oral malignancy? Most sensitive and specific, anyone, or is it?
I told because it's actually complementary, CT and MRI. So when you want to evaluate the tongue or the floor of mouth, always MRI takes up, because it can clearly show the involvement of the intrinsic and extrinsic muscles and extension to the cerebral space, invasion of the myelin head, all those things. But when it comes to the bone or the buccal mucosa, because we have a very good technique, puff cheek technique, which can throw out the mucosa laterally, and we can show the lesion very clearly, extension to the buccogingival sulcus, and important is the bone erosion can be made out best on a CT. So we have to use based on the subsite of the oral cavity, the type of the imaging modality.
Thank you, sir. It was indeed a very informative session, sir. Thank you for accepting to be the resource person, and
thank you, ma'am. It's my privilege And I've been always coming here for your CBCT workshops, and I am very happy to interact with the whole department for this kind of talks. It actually enlightens my knowledge as well, because we do more of a large soft tissues, abdomen, thorax. Unless you people send us the cases, and we'll not get enlightened with these kind of findings. Thank you.
Thank you, sir. Thank you so much.
Thank you.
That was the last talk of the day. I will reconvene later in the afternoon at 2 o'clock for the third guest lecture. I request all the poster presenters to log in via the Google Meet link given to them. Thank you. We'll meet again in the afternoon at 2 o'clock. Good afternoon, sir. Good afternoon, everyone. We'll now commence with the third guest lecture of the day by Dr. Kainikal CT on the topic Role of Radiotherapy in Oral Cancer. I request Dr. Kumudar, Leader, Department of Oral Medicine and Radiology, to introduce the speaker. Sorry, there is some technical issue. Few minutes, sir.
Am I audible?
Yes, you are.
Good afternoon, everyone. Myself, Dr. Kumudar Rao. I'll be introducing our speaker for the session, that is Dr. Kainikal CT. He will be speaking on role of radiotherapy in oral cancer. Sir is presently working as additional professor in the Department of Radiation Oncology at RCC Trivandrum from October 2017. Also, he has great qualifications to his he has completed his MBBS from Medical College Kottayam in 1998, DMRT training from Regional Cancer Center Kerala, that is Trivandrum, Kerala in 2004, MD in RCC, that is Kerala University Trivandrum in 2005. He completed his DNB with a gold medal, and he was the first rank holder in 2005 from New Delhi National Board of Examinations. He completed his MRCP in Medical Oncology from Royal College of Physicians in 2018. He has many international and international conferences and presentations, both poster and paper presentation to his pursuit. His ongoing research projects as principal investigator and co-investigator are principally in the field of radiotherapy in head and neck cancer, advanced squamous cell carcinoma of the head and neck cancer, nasopharyngeal carcinoma, palliative chemotherapy, therapy in oral cancer, chemoradiation, to name a few. He has also international training from ESTRO, training in tumor volume delineation in radiotherapy, Prague from June, that is in 2008, evidence-based radiation oncology, that is methodological basis and clinical applications from Bali. He has undergone training also in biological basis of cancer therapy from Christie Hospital, Manchester in 2009. And he has finished a course in radiation biology, Christie Hospital, Manchester in 2010. He has been a speaker in many international conferences as well as in meetings and presented numerous regional and national training meetings by the Indian College of Radiation Oncology. He has numerous academic contribution in the national as well as international level. For example, he's a member of the ICMR subcommittee for the formulation of guidelines for the management of CL larynx and hypopharynx. He has presented RCC, that is head and neck data in ICMR meeting twice, and he is faculty for chart rounds, that is for India. He is the Indian College of Radiation Oncology. He is presently the postgraduate and PG teaching faculty. So we welcome you for the session.
I sincerely thank the kind invitation. May I share the slides?
Yes, sir, please.
So I know this is not the right time to listen to a lecture. So I'll try to make it as brief as possible. So the broad topic which is given to me is the role of radiotherapy in oral cancer. It's a broad topic. So I will try to discuss with some clinical situations that will be more useful for the residents. So any malignancy, when you discuss any malignancy, not alone head and neck cancer, when we discuss any approach oncological problem, we need to consider certain situations before deciding the treatment, certain conditions. So one is the stage of the disease. Okay, what stage the patient is having. Second, what is the age of the patient and performance status. What are the comorbidities patient is having? So whether the patient is fit to undergo the planned treatment. Then the nutritional status. This is also very important for the execution of the treatment, the complaints of the treatment. What are the available facilities and the expertise available in the treatment center? And what is the family and social support? So this is all are equally important in deciding the execution and the outcome of any oncological. Same is with cancer. So when you have a head and neck squamous cell carcinoma, the most common site is the oral cancer. Other sites are oropharynx, larynx, hypopharynx, and nasopharynx is considered as a separate disease. So these are the 4 subsites which are common for the head and neck squamous cell carcinoma. So the basic principle in the management is more or less for all subsites. Although there is an increased role for surgery in advanced oral cancer that I will discuss later. In early disease, in head and neck squamous cell carcinoma, all put together, in early disease is stage 1 and stage 2 disease. That is early disease. Stage 1 is T1N0. What is T1N0? If it is a clinically, is less than or equal to 2 centimeters. That is clinically T1, and no nodes. That is T1N0. T2 is any tumor between 2 to 4 centimeters, and there is no clinically evident nodes. That is T2N0. So in early disease, stage 1 and stage 2, our aim is to have a cure because most of them are, as majority of the patients will be get cured with a single modality, can be either radiotherapy or surgery. So I will be discussing more focusing on radiotherapy, but I will discuss surgery also. Then only you will be able to understand which patient should undergo it, which patient should undergo surgery. Advanced disease, that is stage 3 and stage 4. Stage 3 means it is T or any node positive disease. Any node positive disease, it is considered as an advanced disease, then it becomes a stage 3. Or stage 4A is patient who is having a T4 or N2, that is stage 4. So all these patients are generally treated by a combined modality approach. Either you give a radical chemoradiation or you consider surgery followed by post-operative. So in advanced disease, our intention is to have a cure, but in stage 3 and stage 4A, it can be either by chemoradiation or surgery followed by radiation. In oral cancer, the gingival complex tumors without a bone involvement can be offered chemoradiation. All other tongue tumors, patients with the gingival complex tumors with a bone involvement are treated by surgery followed by post-operative. In patients who have an advanced disease, that's a stage 4B disease. That is a patient who have T4B disease or patient who have an N3 disease. Generally, they are treated by a palliative treatment. If the patient is having a very advanced disease, T4B disease or N3 disease, generally they are treated by palliative treatment and radical approach in highly selected patient. Stage 4C means the patient who is presenting with distant metastasis. Generally, they are treated with palliative. Stage 4B means it is T4B or N3 disease. That's a very advanced nodal disease. Okay, I will discuss what is N1, N2, and N3. That's a broad outline in the management. The patient is having very early disease. You can see a very proliferative verrucous lesion in the left lateral bone. tongue. You can see the lesion is confined to the lateral bone, and this patient had no nose. It's a T1 disease, very less than 2 centimeters. Or a patient who have a lip disease like this, very early disease. And in this group of patients, the intention is mainly cure because it is early disease, and the treatment can be either radiotherapy or surgery. In this group of patients, our intention is to have a cure. Okay, in early disease, let's say aim is it's a clinically staged disease. Then in such situations, there is no point in doing an MRI or CT scan because it's a clinically staged disease. There is no need to do a EEG. The treatment is either radiotherapy or surgery. The aim is cure and reduce the morbidity of treatment. So you have to use a modality where radiotherapy or surgery, which is likely to reduce the morbidity, the long-term morbidity of the treatment. So in early disease, the functional outcome is one of our major goals apart from cure. And what are the expertise available for? Expertise for brachytherapy, expertise for surgery, then the morbidity due to whether it is radiotherapy or surgery, and the patient's preference. We will give the options to the patient, and the patient is the king, and patient has to decide. In a patient who has a T1 tongue or a patient who have a lip disease, they can be treated with brachytherapy. So this is a T1 disease in the hard palate. We have a lesion here. The CT scan here. This CT scan we have to do because in the hard palate, the bone involvement is highly common. So then the treatment is different. Then you have to take a CT scan. The bone is negative. Then is this commercial customer, no nodes. That is, you do an ultrasound or a CT, then there is no nodes. Then standard treatments to go for a brachytherapy. So you use a mold in this situation, and to use a mold, then that will be the curative treatment. In a patient with a stage 1 disease, that's a T1 N0, see a tongue or see a lip, the patient can undergo brachytherapy. And patient proper selection of the patient is very important. The patient should have a T1 disease, and histologically it should be well differentiated histology. And in ultrasound, the ultrasound of the neck should be negative, and it should be a T1 disease, superficial lesions. And most important thing is that the patient should be ready for close follow-up. That's also very important. The patient should be ready for close follow-up. Why it is important? Because otherwise the patient, if the patient is lost on follow-up, we are not treating the neck. In that situation, the patient may come back with an inoperable nodal relapse. We may lose the patient. That is the reason why I say this patient should be ready for close follow-up. So the brachytherapy can be either, it can be a high-dose rate that we follow, that is high-dose brachytherapy. The treatment can be completed within 6 days. So you give 2 fractions a day. You give 1 fraction in the morning and 1 fraction in the afternoon. So you give 4 gray PI, means 4 gray of 4 gray. So for 6 days, that is 8 gray in 6, that's 48. That is 48 gray in 12 fractions over a span of 6 days. And the most important thing is the close follow-up. Patient should be ready for close follow-up because we are not treating. And all the published results have shown that if you give a lip cancer disease, a T1 or a T2 disease, then the 5-year local control is around 95 to 90%. This is international recommendation regarding the brachytherapy early on. Now we'll take another clinical scenario. So first we discussed a T1 tongue, have shown you a lip disease. There is a mode therapy for a T1 heart. Now we will discuss a few clinical scenario regarding buccal mucosa. In buccal mucosa, it's a T2 buccal mucosa. It's a T2. We can see a varicose lesion in the left buccal mucosa extending in lower inflammation. And this is again a similar lesion. There's a proliferating disease, lesion involving the lower inflammation. And also in the aspect of bleeding, and also the lower GB cells was involved. And the retromolecular is a T2 disease. Same is the situation here also. It is extending into the retromolecular. Lesion is involving the retromolecular and the lower mucosa, lower gingival surface is involved. Upper gingival surface is free, and the oropharynx seems to be fine. It's just a T2 disease. CT scan show bone body. In this group of situations, you need to evaluate the bone properly with a CT scan to rule out a bony involvement. It is coming to the lower palate. This is also lesion in the hard palate at the junction of the hard palate. So this is a T2 disease. And in this patient, whether this patient should be treated with radiotherapy or surgery. And this is another lesion extending. There's a T2, this is a verrucous lesion, again T2 disease. T2 disease, verrucous lesion. How to treat this patient? You have two options for these patients. You can do a biopsy, and after the biopsy, you can, in certain situations, you need to have a CT scan. If you have an upper GB sulcus involvement, lower GB sulcus involvement, the gum is involved, the patient is having a retromolar trigon, then this patient should have a CT scan. After the CT scan, then you decide the treatment. So you can have two options are there. There is no, you cannot say that radiotherapy is superior to surgery or surgery is superior. But in this group of patients, you can choose either way. In our institution, most of these patients are treated by. You have radiotherapy 66 to 70 day, dose, or you can have a wide excision plus a supramohai neck dissection plus marmaxillary reconstruction. It's also equally effective modality. So local regional control is same, but depending on the functional outcome, then radiotherapy may score over surgery in patients with exophytic lesions in our liver, especially those who are coming close to the liver. Then radiotherapy have an edge over surgery. So these are few examples of patients who have treated with radiotherapy left bundle with good outcomes in the opening. There is no trismus, no long-term toxin. These are all taken after 5 years of long-term. So these are all good outcomes with radiotherapy. This is again another situation. So you can even make out, you cannot even make out. That's the techniques of the new radiotherapy techniques. You cannot even make out. If you see this patient in the market or in the street, you will not be able to know this patient has received a radical radiotherapy for a T2. Yes, this is our contribution because we have done a phased pilot trial study comparing two radiotherapy schedules, comparing 7-degree in 35 fractions. And this next paper was comparing the two radiotherapy schedules. That is a phase 2B trial. So in the pilot study, what initially we presented this data in the Head and Neck Gastro Symposium in US in 2014. And this stage 1 and stage 2 gingival complex tumors were randomized to 70 grain 35 bases, 5250, 55 to 52.5 grain 15 fractions. And it is found that there was a trend towards higher disease-free survival in patients who received a 3-weekly schedule compared to 7 weeks of radiotherapy. Response rate, there was no outcomes, no other difference in outcomes. So it was found that 3 weeks of a hyperfractionation radiation is found to be more or less similar outcomes in patients who received a protracted 7-degree infections. And thus we went one step ahead and we randomized, we have done a phase 2B trial. And this was presented in Shanghai in the Asian Oncology Summit. This is same similar situation, same dose compared. It was found that the complete response rate and the patient was better in patients who received it for 52.5 infections compared to 7-degree infections. So to summarize the early disease, if you have a T1 oral tongue, okay, then T1 oral tongue. I will discuss T2 tongue later. T1 oral tongue, you have brachytherapy or surgery, and it will give you equal disease. The oral tongue, it is always surgery. Okay, I will discuss that later. And no gingival complex tumors, exophytic T1 or T2, definitely you should consider either a brachy or an external radiation. In hard palate T1 and 0, please avoid surgery. In this group of patients, go for a brachy provided a bone is intact. This will give you a very good outcome. Bone brachy. In T1 and T2 disease, you can consider EPRT because when you do a surgery, there will be a defect that needs to be repaired. So if you give radiotherapy for a hard palate lesion, especially exophytic lesions, this will give you a very good prognosis and functional outcome. Lip T1 and 0 prefer. And for a T2 lip, you can either consider brachy plus an external BBRT. BBRT plus brachy boost or this is my personal view of putting the radiotherapy for in early organs. Coming to tongue tumors, they are more aggressive compared to gingival complex tumors. It is, we have to be more respect the tumor. There is a high chance for a nodal involvement. If you treat a gingival complex tumor, most of the relapses occurs in the primary site. But if you treat a tongue tumor, most of the relapses occurs in the neck. Okay, that's the difference in relapse pattern. And gingival complex tumor. Okay, oral tongue. Here it is oral tongue CT2 and 0. This is a 63-year-old gentleman. This is a performance status 1 and carcinoma tongue in the lateral border. It was 2.5 into 2.5 centimeters. and clinically no nodes. So it is a T2 N0 disease. It was a stage 2 disease. And this patient was planned for a wide excision plus a supramohenic section. And it was primary occlusion was done. In this group of patients, there is no need to do an MRI if you are doing it under a frozen guidance. In early disease, T1 and T2 oral can be staged by clinically. But if you have a T3 and T4 disease, or you do not have a frozen facility to have a section of frozen guidance, definitely MRI may be an option before considering patient for surgery. So when you deal with the surgical treatment of an early oral cancer, you have three components we have to consider. One, the treatment of the primary disease. Do a wide excision with a three-dimensional clearance. And the neck treatment is also equally important because head and neck disease, we need to treat the primary as well as the neck. So regional treatment is very important. Then in an N0 neck, you have to do an elective neck dissection. The elective neck dissection in early oral cancer is a supramohenic neck dissection. It's level 1 to level 3 clearance. And in a T1 disease, you may not need a reconstruction. In a T2 disease, you may require that. So otherwise, you will go for it. So that is early disease. Why you need to consider the neck nodes in a T2? Because we have seen the case. The chance of lymph node involvement in oral cancer in the oral tongue is around 29%. So treatment of the primary is a long. Let's say it is a cardinal sin if you do only a wide excision for a T2 tongue and without undressing. The neck treatment is mandatory. The neck treatment have shown an improvement in survival. The elective neck nodal disease, this is a randomized trial done in TMH. And it was an elective neck dissection versus therapeutic neck dissection in early oral cancer, a T1 or a T2, clinically no negative disease. We are randomized between elective neck dissection versus therapeutic dissection. The primary endpoint was overall survival. And it was found that those patients who received, elective neck dissection had an improvement in survival, and there was an improvement in disease-free survival as well. So it means that the elective neck dissection can save lives, and always you should consider dissection as part of the treatment. So after surgery, then you should have a proper pathology report to decide the adjuvant treatment, whether the patient can be kept on follow or whether the patient needs further treatment. So for that, this is a checklist. So you have to do a primary site. Where is the primary site? What is the tumor size? What is the histology? What is the grade of the tumor? Whether it is in lymph node, whether it is which level of lymph node is involved, what is the number of lymph nodes involved, what is the maximum amount of the size of the node involved, whether the extracapsular extension is present, a perineural invasion is present, lymphovascular invasion is present, whether the skin is involved, whether the bone is involved, the surrounding muscle is involved. Then these are all need, and that is how this is a long list, and that's how we decide the adjuvant. We will take few clinical scenarios. Okay, this is situation, same patient under surgery, and after surgery, these tumor size is 2.5 into 2.5. The margins are negative. When you will say margin is negative when the clearance is more than 0.5 centimeters. So 0.1 to 0.5 is considered as close margin. Less than 0.1 is considered as margin. Positive or ink margin is positive, is considered as margin is positive. Then the margin is negative. It is a PT2 because it is a 2.5 to 2.5 centimeter. Then depth of infiltration is 0.6. This is very important. The depth of infiltration is a new addition to the disease staging of oral cancer. So then this is a PT2 because of two things. One, 2.5 into 2.5 centimeters. And depth of infiltration is between 0.5 to 1 centimeter. Then that also is an independent criteria to label as T2 disease. So it's a T2 disease because of two things. Then no other adverse features like perineural invasion or lymphovascular invasion, and the margin is negative. In this group of situation, the 0 out of 18 nodes. So supramohenic neck dissection was done. The 18 nodes were sampled, all are negative. Then how you will calculate the depth of invasion? So depth of invasion is how you will calculate. So this is the and you establish the horizon at the level of the basement membrane. So this is to establish the horizon at the level of the basement membrane. This is the level of the basement membrane. This is the level of the basement membrane. Close to the intact. So you can see this intact. And these are infiltrated tumors. So close to the intact mucosa, you establish a horizon at the level of the basement membrane. Then you draw a plumb line from there to the maximum area of This is the depth. And this depth is considered as the depth of. And tumor thickness is different, and this is the depth of. And if it is less than or equal to 5, then it is T1. And suppose even if the tumor is less than 2 centimeters, but the depth of infiltration is more than 5, it becomes a T2 disease because that's an independent criteria. That is T. So after this, if no adverse features are present, in this patient no adverse features, then there is no need for any adjuvant because the adjuvant treatment is radiotherapy. There is no need for adjuvant. So in early disease, stage 1 and stage 2 disease, no adjuvant treatment is required. Now we are coming to another clinical situation. So if this patient had a margin is negative and same patient, but the depth of invasion was 1.2 centimeters. So up to 1 centimeter, the depth of infiltration is this. If any depth of invasion more than 1 centimeter, then it becomes a T. So here you can see that. So this is T3 because the depth of invasion is more than 1 centimeter. So any tumor between 2 to 4 centimeters or with depth of invasion less than 1, this is T3. When it becomes T3, becomes any tumor that is of more than 4 centimeters with depth of invasion. So any 2 to 4 centimeter, then if depth of invasion is more than 1 centimeter, then it becomes a T. So this patient had a 2.5 to 2.5 centimeter. Depth of invasion was 1 centimeter. Then it becomes a T. So coming to this are all clinical situations we encounter in the OP daily. That's why I'm putting, I'm taking case progress. This patient had undergone a wide excision outside. The median margin was positive. The size was 2.5 to 2.5 centimeter. And again, the no nodes were positive. So if this median margin is positive, whether to go for a adjuvant treatment or do a revision surgery. In this situation, I'm not an advocate for radiotherapy because if you do a revision surgery, then you can avoid radiotherapy altogether in this patient because there is no other indication for revision in this patient. In that situation, you should do a revision surgery. Here, a PT2N1 disease and single node is positive. Give radiation because it's stage 3 disease. Any node positive is a stage 3 disease. So there is some argument that this radiation is required, but we have achieved more or less a consensus that this patient should have a radiotherapy because of in a PT2N1 disease, there is an improvement in survival if you give radiation in these patients. So even in a single node positive, it may be better to consider adjuvant radiotherapy. That is same as the new guidelines. This is the 2022 guidelines also same. In a single node positive disease, without adverse features, you consider adjuvant. So how will you follow up an early disease? Suppose a patient had undergone surgery, undergone radiotherapy or surgery, how often you have to evaluate the patient? If a patient has undergone radical, there is no point in evaluating the patient before this. Okay, the first, when you will say it is a radio residual disease is there, then at 12 weeks you evaluate the primary as well as the secondary. Both of them are in remission, then the patient follow up. The patient is having a radio residual disease after 12 weeks, then that's an indication for doing salvage surgery in a patient who had undergone radiation. The patient has undergone surgery. There is no point in seeing the patient so often. So you have to see only 2 to 3 months in the first year, and in the second year 3 to 4 months, and after 2 years, most of the relapses occurs within 2 years. Majority of the oral cancers relapse within 2 years. That is why we should have a more stringent follow-up in the first 2 years. After 2 years, then you can increase the duration of your follow-up from 4 to 6 months. Then after 5 years, it's yearly. There are 3 goals for follow-up. 1, to know the disease status. What is the disease? Second, to know the complications due to it. Suppose a patient has received radiotherapy, any long-term complications. Third is the patient is developing any new crime because most of the patients are having habits, smoking or alcoholism. In that, many patients may develop primary elsewhere, like lung or in the esophagus or in the upper urodigestive tract. So you have to keep a track on this. The patient develops any other new urodigestive tract. It's called field cancerization. So coming to the advanced disease, so we were discussing the early disease. Now I will discuss the advanced disease. Advanced disease like a T3, T3N0, or a T1 or a T2, T2 complex disease. These patients can be either treated by chemo, radiation, or surgery. In a patient with a T1 or a T2 with node disease or a T3 disease with a node, then if you give chemo radiation, they have a better organ participation functional outcome compared to surgery. Yes, coming to the advanced disease situation. So coming to a tongue tube, so this is a little more advanced. This is T2, again T2. This patient had nodes also. Patient had 1B and level 2. So 2 nodes, then it becomes N2. So it's a T2 N2 disease. The patient, the moment the patient is having a T2 N2, then it becomes a stage 4 disease. Okay, then how you will evaluate this patient? Okay, before the discussion of this advanced disease, then you have to know what is N1. So when you evaluate the neck, 4 parameters will be used. One, whether the node is single or multiple. Second is whether it is the same side, lateral or contralateral. Then what is the size of the node? Whether any clinical signs of external extension. What is N1? N1 is if any node is present on one side, it is less than or equal to 3 cm. Mobile node, and is on single node and it's on the same side. And there is no features of external, means there is a mobile, then it becomes an N1. But if you have a big brother of N1 is N2. Suppose N1, same criteria, lateral, single, less than or equal to 3 cm, no signs of external extension. Same node if the size is between 3 to 6 cm. That's a big brother of N1. That is called N2A. N2B means the patient has multiple nodes on one side. No contralateral nodes, and all of them do not, any of them, if all do not have there is no evidence of any extracapsular extension. And most important thing is that none of them should be more than 6 cm. Any node more than 6 cm, it becomes N1. So it should be multiple nodes, it should be ipsilateral, none should be more than 6 cm, and there should not be any evidence of any extracapsular extension. Then if the patient has bilateral nodes or contralateral, then it becomes an N2. Suppose if a tumor is in the tongue here and the patient is having a node on the opposite side, then it becomes an N2. So bilateral or a contralateral, done more than 6 cm in dimension and no evidence of an extracapsular extension. N3 disease means two things. One, if a patient is having any node more than 6 cm, or if the patient has any extracapsular extension, then generally in head and neck, they are considered for palliation because they are stage 4 disease. But in selection, in good selected patient, you will consider radical. We cannot consider all N3 fantastic. Because if a patient is having a young patient, small primary, and N3 node, there is no evidence of any ulceration, no evidence of a carotid artery. That's different compared to a patient with a large primary, elderly patient with a big node filling the entire neck with ulcerated node. Then this is a different situation. So you have to individualize such situations to have it. So I'll discuss another talk, then I will discuss the management. This is a 68-year-old lady, performance status 1. Patient had a T3 disease and patient had an N2A. This patient had an N2A node. And this patient, N2A node means any node more than 3 cm and less than 6 cm. And it is mobile and no evidence of the extracapsular. In this group of patients, how will you approach? Or a patient with, suppose this is again an advanced disease, a buccal mucosa disease, extra involving the bone. This is a T4A disease with the bone involved. Then it becomes a T4A. The patient has submandibular and the level 2 also. So this is a T4A N2B disease. In this group of patients, standard treatment is to go for surgery. So I will take this situation. This patient may have to undergo a left hemimandibulectomy, a modified radical neck dissection, because you have to address the neck also. Then you have to do a reconstruction of this bone by a graft, either maybe a tibia, a fibula graft, or maybe a plate. Then you have to do a post-operative. This becomes a planned treatment. So it becomes a planned treatment. Okay, now all patients in advanced disease, suppose a patient is having tongue disease advanced disease, but either due to the advanced nodal disease, a patient is having a mandible reconstruction, generally they go for surgery. And surgery followed by post-operative. It's a planned treatment. So the patient should have enough reserve to undergo planned treatment. Suppose a patient is having 76, patient is having performance status. There is no point in taking that patient for a surgery because you should know when I'm sending a patient for surgery, I should be very sure that this patient will be able to complete the adjuvant radiotherapy, which is required as a planned treatment. Not possible, there is no point in surgery because it is half treatment. Yes. So the surgical treatment of advanced disease includes a primary treatment of the treatment of the primary disease. So you should have a wide excision. Then the pathological clearance should be 0.5 centimeters. The classic teaching for the advanced disease, you do a modified radical reconstruction or level 1 to level 4 clearance because the involvement of the nodal involvement in level 5 nodes, posterior cervical nodes are less. But you have to do a level 1 to level 4 clearance. Then always you should have a reconstruction. Now in this group of patients, so I will give you a clinical scenario. So this patient, the same patient, PT2 N2 disease, the patient underwent wide excision and MRNT. Then this patient had underwent surgery, margins are negative, 1 out of 18 nodes are positive. Then it becomes 1 out of 18 nodes, it becomes an N1, but there is a catch there if the extracapsular extension is there. There's no, it is less than 3 centimeters. And if the extracapsular extension is present, then it becomes an N2 disease. It was a clinically T2N1 disease, but it turned to be a pathologically N2A disease because it is a single node, less than 3 centimeters, showing an extracapsular extension. If any node, if the node size is more than 3 centimeters, the pathologically involved node is more than 3 centimeters, and extracapsular extension is present, or if multiple nodes are there, positive, multiple nodes are involved by the tumor, and if any one of them showing an extracapsular extension, then irrespective of the number of nodes, then it becomes a N3 disease. But in a single node, less than 3 centimeters, and extracapsular extension is present, then it is considered N2A. This is T3 because it is a 2.5 to 2.5. Depth of invasion is 1.2, and it becomes a PT3 N2A. It is a stage 3 disease. Okay, this if the size is more than 3 centimeters and extracapsular extension, then it becomes an N3 disease. And if single, multiple nodes and one of them is showing extracapsular extension, that is also N3 disease. Now coming to the surgery is in advanced disease. I said all the advanced tongue tumors and geometric complex tumors will go for surgery. Then the concerns is there any role for chemotherapy before surgery? That is another question. As of now, we see that there is no evidence to say that the induction chemotherapy has a role in oral cancer. Because if you give induction chemotherapy, there are 2 major studies have shown that there is no improvement in local control or overall survival, but there is a preservation of mandibular resection rates are less, or the mandibular preservation rates are high. Then compared to the pre-op radiation versus post-op radiation, because there was a study comparing pre-op versus post-op, just found that post-op radiation is better than pre-op. That is why the patients undergo surgery and advanced disease, then you go for a post-op radiation. What is the minimum dose of post-op radiation? It is 57.6. The overall treatment radiation should be completed within 100 days of surgery. That is 100 days. Then no role for chemotherapy in operable disease. Altered fractures radiation is not found to be of superior benefit. Those patients are margin positive or extracapsular extension. Suppose a patient we discussed a few situations. Extracapsular extension is there. The patient has extracapsular extension or patient is having margin is positive. And if the patient has good performance status, then you should consider post-op chemotherapy because post-op chemotherapy is the standard adjuvant. But this should be considered with caution because the patient should have excellent performance status. Okay. This why? Because a patient is having altered liver function, elderly patient, fragile patient, never consider them for a post-op chemotherapy. Take it from me. The post-op chemo radiation is in head and neck is one of the most toxic treatments in solid because there is a chance for mortality due to post-op chemo radiation. So you have to be very vigilant in taking these patients. And usually you give a 3 weekly cisplatin, that's a standard. And recently there is a data to be cisplatin also. There is no role for any target. And many people may ask, is there a role for adjuvant chemotherapy? Can we avoid radiation? Because the adjuvant chemotherapy in head and neck cancer has avoiding radiotherapy can have a negative impact, and it should not be given in head and neck cancer. Then I will briefly touch upon a few situations where we will consider for palliation. So this is, you can see that the inter-incision distance is less. I'm not the right person to comment on this because you are the judge there. So in this group of patients, you can see a lesion there. This is a buccal mucosa disease involving the skin. And the patient had a it is a 76-year-old lady, PS2. And will you consider this patient for surgery? Because we know that this patient will not complete the surgery for storage. This trismus may be due to investigator space involvement. And so you have to have a CT scan to know the status of investigator space, infratemporal foci, etc. But if you can clinically make out that the performance status is poor and the age is 76, generally you will not consider a CT scan for this patient. My personal view is that the cost of one CT scan will be lifetime palliative chemotherapy. So I will not consider this for any CT scan. So it's a clinical judgment. We consider that patient for palliative. I need a biopsy. So this is again a situation where very advanced disease, patient is having trismus and extensive skin involvement, infratemporal foci involvement, and patient had a cutaneous nodules. It's a straightforward case for palliation. And I need only, suppose if I have a node there, then I will look for an FNAC from there. A biopsy thoroughly may not be accessible, or you have to take an FNAC from there. So you will try to get a histological proof, then you will start the patient with palliative. This group of patients, generally palliative radiation is required because this can aggravate trismus and the quality of life will deteriorate. But if a patient is having buccal mucosa with no trismus, because the elderly patient, then you are considering palliative radiation. And I am a hardcore fan of weekly palliative radiation, but not for this patient, because this patient is having a young patient, but the patient is having a trismus, then palliative radiation may have a negative. So which patient should undergo which? Sorry. Considering which are the patients we should consider them for a palliative treatment? If a patient is having extensive trismus, a patient who have extensive skin involvement, or patient who have cutaneous nodules, clinically there is an inflammatory involvement. Or radiologically, if a patient is having intracranial extension, or skull base involvement, any aerodartery encasement, or in a very advanced generally we will go for palliation. And clinically, if any of these features are present, avoid unnecessary investigations and consider them for. This is one of the CT scans, very advanced disease. You can see that the lateral pterygoid muscle is indicated, great destruction is there, infratemporal foci involvement is there. Generally, these patients will not have. So coming to the last slide, okay, if you look into this is from the TNM classification of the 8th edition. So what we have achieved over the years is if you have a T1 disease like this, the 5-year survival is around 80 to 90%. If you have a T2 disease, the green one, the survival is around 70%. So this one, 5-year survival. If you have so this is around 70 to 80%. If you have a T3 disease, it's a T3 disease. It's around 50 to 60%. If you have a T4 disease, the 5-year survival is around. why we need to understand. If you have a very advanced oral cancer, but in spite of improvement in radiotherapy techniques, in spite improvement in surgery techniques, new molecules in the form of action chemo, target agents, all the improvements in medical have not shown any improvement in the 5-year survival in the last 3 decades. So it remains the same. So we have to be in early disease, I will summarize. In early disease, it is radiotherapy or surgery. In patients who have candidates for brachytherapy, definitely they should be offered brachytherapy. In patients with exophytic disease in gingival complex tumors, they do very well with radiotherapy. In tongue tumors, T2 onwards, generally they are treated by surgery alone. Gingival complex tumors, T3 disease, and selected T1, T2 with no disease can be treated by radiotherapy, chemoradiation. All advanced tongue tumors and the gingival complex tumors with bony involvement up to stage 4, that is by surgery followed by planned postoperative. In T4B or N3 disease, it is palliative treatment. Thank you very much for your patient listening. I sincerely appreciate it. If you have any queries, then you can just email me, or this is my WhatsApp number. If you need these slides, I'll be very happy to give this for the benefit of the residents. Thank you very much for your patient listening and for the invitation. Over to you.
Thank you, sir. It was a very informative session, sir. We'll open the session for questions. There are some 2 questions, sir. I will ask you.
Sure.
Percentage of incidence of oral adverse effects if they're secondary to head and neck radiotherapy, sir?
Okay, so you mean you are concerned with the osteoradionecrosis because there are many factors are there, because there can be fibrosis, xerostomia, all these are there. So there are definitely there are long-term toxicities there, but these are, if it is properly taken care of during and after the treatment, you can definitely reduce them. You can definitely have a proper functional outcome. There are small percentage. Suppose if you take, the factors which you decide the long-term toxicities are: 1, what is the dose per fraction you use? What is the volume irradiated? Suppose if you give a large volume buccal mucosa disease and whole neck with a high dose per fraction, this can lead on to a lot of issues. But the newer radiotherapy techniques, the toxicity is very less. Okay, because we are able to target the area where you want to give radiation. Then you can reduce the dose to the critical structures. You can spare the carotids. You can spare the other organs in head and neck region. So the morbidity has been come down drastically. If you look into the papers, definitely you will come across some very figures, because mostly that was in the cobalt era. But due to the techniques in radiotherapy, definitely it has come down. There is some problem with your...
Yes. What are the expected systemic effects of radiotherapy?
Radiotherapy is a local treatment, okay, because generally the patient, suppose if a patient give radiation to this area, the hair loss will be there. Skin pigmentation cannot. Okay, only that area where you are giving radiation will have an impact. So you will not have, suppose if I irradiate a buccal mucosa tongue, you will not have any issues to your testes or ovaries or any systemic. There is no. Okay, you cannot see.
Okay, sir. That's all the questions been asked now. Thank you, sir. Thank you so much for the wonderful session. It was great having you, sir, with us here. And we'll be sending the certificate of appreciation to you. Thank you, sir. Thank you so much.
Thank you very much. Thank you.
Thank you, sir. I'm sure everyone had a great learning experience today. We'll reconvene tomorrow morning at 10 a.m. For the other 2 scientific sessions that we have lined up for tomorrow. So thank you. Thank you, one and all.